application. This is an Office of Health Strategy application filed by applicant Windham Hospital. This is docket number 20-32405-CON. In the application, applicant seeks to terminate inpatient services offered by a hospital. More specifically, the application states that applicant is seeking the termination of inpatient obstetrical services at Windham Hospital. This public hearing before the Office of Health Strategies Health Systems Planning Unit is being held on November 10th, 2021. Public Act 21-2, Section 149, effective July 1, 2021, authorizes an agency to hold a public hearing by means of electronic equipment. In accordance with the Public Act, any person who participates orally in an electronic meeting shall make a good faith effort to state your name and title at the outset of each occasion that such person anticipates or that such person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute the device that they are using to access the hearing and silence any additional devices that are around them. This public hearing is held pursuant to Connecticut General Statutes, Section 19A, 639A, and will be conducted under the provisions of Chapter 54 of the Connecticut General Statutes. My name is Joanne Villando. Victoria Valtri, the Executive Director of the Office of Health Strategy, has designated me to serve as the hearing officer for this matter, to rule on all motions and recommend findings of fact and conclusions of law upon completion of the hearing. Office of Health Strategy staff is here to assist me in gathering facts related to this application and will be asking the applicant witnesses questions. I'm going to ask each staff person assisting with questions today to identify themselves with their name, spelling of their last name, and their OHS title, starting with Mr. Carney, please.
Good morning. My name is Brian Carney. I'm the Certificate of Needs Supervisor at the Office of Health Strategy. My last name is spelled C-A-R-N-E-Y.
Good morning. My name is Ronan Roy Wong, last name W-A-N-G, and I'm an Associate Research Analyst at the Office of Health Strategy.
Thank you. The Certificate of Need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant, members of the public, and our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being recorded and will be transcribed. All documents related to this hearing and that have been or will be submitted to the Office of Health Strategy are available for review through our Certificate of Need portal. Now, through the hearing, you'll probably hear reference to CON standing for Certificate of Need. The CON portal is accessible on the Office of Health Strategy's CON webpage. In making my decision, I will consider and make written findings in accordance with Section 19A 639 of the Connecticut General Statutes. The CON portal contains the table of the record in this case. As of this morning, exhibits were identified from A to U. All public comment can be found under Exhibit F. In accordance with Connecticut General Statute Section 4-178, the applicant is hereby noticed that I may take judicial notice of the following documents. The State Facilities Plan, OHS Acute Care Hospital Discharge Database, Hospital Reporting System Financial Data, Bed Need Methodology, Hospital Reporting System, known as HRS Report 400, Hospital Inpatient Bed Utilization by Department, All Payer Claims Database, APCD, Claims Data, Connecticut Vital Statistics Registration Reports, 2010 to 2019 provisional. Windham Hospital Community Health Needs Assessment for years 2015, 2018, and 2021. I may also take administrative notice of prior OHS decisions and agreements regarding Windham Hospital and other OHS final decisions that may be relevant to this matter. Mr. Carney, are there any additional exhibits to enter into the record at this time?
Attorney Yanda, I'm not aware of any additional documents. There may have been a late submission for a public comment that needs to be incorporated with the public comment file. That's the only one I'm aware of.
Okay, thanks. And as those comments come in, they will be placed under Exhibit F. Counsel for the applicant, would you please identify yourself for the record?
Yes, this is Jennifer Fusco, counsel for Windham Hospital.
Okay, and I do know there's another counsel of record. I'm not sure. I know Attorney Fusco, you will be the lead counsel here. I'm not sure if other counsel would like to identify yourself.
Yes,
Sure.
Jackie.
Thanks, Jennifer. Jacqueline Hurl, Associate General Counsel for Hartford Healthcare.
Attorney Fusco, are there any objections to the exhibits in the table of record or the notice documents?
Yes, I do have some objections and requests for clarification. So there was a letter submitted by my office yesterday in response to a letter submitted by Generations in the public comment file. I don't know if my response gets filed with the public comment or if that's a separate exhibit, but that's not reflected on the table of the record.
I think that's going in as Exhibit V. I just don't think it's made it
Okay.
in yet. Mr. Wang, can you clarify?
That is correct. It will be
Okay,
exhibit B.
It will be entered in as Exhibit V.
Okay, and then just two comments or requests with respect to Exhibit F, the public comment file. So on pages 187 to 188 of the PDF, there is a public comment in there about the Sharon Hospital Obstetric Unit. I know there had been several in there when I looked last week. Most of them are gone, but there's a new one in there if that can be moved to the correct file. And then there's a letter that went in, I don't know if it went in last night or this morning. It's from an attorney, Dennis O'Brien. It's requesting reconsideration of the CON determination from 2015 regarding Windham Hospital's ICU. That has nothing to do with this proposal, and I don't think it properly belongs in the public comment file here, as opposed to the public comment file in that CON, and that's on pages 201 to 206.
It was entered in, he filed it, I believe, as public comment to this. I mean, we will take public comment as, whatever's relevant is relevant. If it's not relevant, I'm not going to, make any kind of determination on a request for a reconsideration on another case. I'm, certainly, I don't know who the parties were in that case. That's not the issue before me, but whatever anyone issues in as public comment, it's going to go under Exhibit F.
Okay, fair enough. Thank you. And that's it. No, I'm sorry. No objections other than that. Those were just my
Okay.
questions.
Mr. Wang, did I address all of that? As far as moving the other exhibit, I don't know if that can actually be moved or we'll just recognize that that document is
Exhibit V.
the one that she said was part of the other one.
Correct. So the applicant's response to that letter will be exhibit V, and then I made notes of the specific sections of the public comment that the attorney for the applicant mentioned. So I have it in my notes.
Okay,
Thank you.
right. All right, thank you. So all identified and marked exhibits are entered as full exhibits. Attorney Fusco, could you just clarify for me the legal name of the applicant? I know it was filed under Windham Hospital. I do see other references made to a different name, including Windham Hospital Community. There's community somewhere in there. I mean, what is the legal name of the applicant?
I think, and I'll clarify this for you when we take a break. I believe that the full legal name is Windham Community Memorial Hospital.
Yes, correct.
I'll verify that that's the actual legal name for you, but I believe it is. It's on the license. Okay, yep.
Okay, all right, thank you. We will proceed in the order established in the agenda for today's hearing. For all those listening in, the agenda can be found on the CON portal. I would like to advise the applicant that we may ask questions related to your application that you feel that you have already addressed. We will do this for the purpose of ensuring that the public has knowledge about your proposal and for the purpose of clarification. I want to reassure you that we have reviewed your application, completeness responses, and pre-filed testimony. As this hearing is being held virtually, we ask that all participants, to the extent possible, should enable the use of video cameras when testifying or commenting during the proceedings. Anyone who is not testifying or commenting shall mute their electronic devices, including telephones, televisions, and other devices not being used to access the hearing. All participants shall mute their devices and may disable their cameras when we go off the record or take a break. Please be advised that the hearing recording continues during the breaks. So any audio or video not disabled will be accessible to all participants and will be recorded. I will try to remind you every time we take a break, but you will want to make note of that. Public comment taken during the hearing will likely go in the order established by OHS during the registration process. However, I may allow public officials to testify out of order. I or OHS staff will call each individual by name when it is his or her turn to speak. Registration for public comment will take place at 2 p.m. and is scheduled to start at 3 p.m. If the technical portion of this hearing has not completed by 2 p.m., public comment may be postponed until the technical portion is complete. There's an outstanding request from applicant in Exhibit R, which includes applicant's request for clarification of hearing notice. Applicant requests that OHS clarify the hearing notice issued on September 22nd, 2021, to acknowledge the statutory provision under which a mandatory public hearing is being held. The notice states that OHS will hold the hearing under 19A 639A F2. As noticed, HOS is holding this hearing. Notice of this hearing was proper. Regarding the applicability of 19A 639AE, the record speaks for itself. Exhibit F includes letters requesting hearings in this matter. My ruling on the request for clarification is not that 19A 639AE does not apply, but that the hearing notice was sufficient. As previously stated, this hearing will be conducted under the provisions of Chapter 54 of the Connecticut General Statutes, which is the Uniform Administrative Procedure Act. Attorney Fusco and OHS staff, are there any other housekeeping matters or procedural issues we need to address before we start?
Not from my perspective, thank you.
We're good.
Okay, thank you, thank you. Attorney Fusco, do you have an opening statement?
Sure, thank you. I'd just like to open briefly, and then I'll cede my time to my witnesses who I think have a lot to talk to you about today. But thanks for this opportunity to make a brief introductory remark on behalf of Windham. The hospital is before you today, as you know, requesting approval to close its obstetric labor and delivery service. The proposal at its core is about patient safety. It's about a need to close a labor and delivery service that can no longer be operated in a safe and consistent manner. And it's about ensuring that the women in the Windham area have access to the highest quality obstetric care in the right environment, even if it means they can no longer deliver at Windham Hospital. You'll hear evidence today that establishes without question that it's no longer possible to safely operate the L&D service at Windham. The unit's clinicians simply cannot maintain their clinical skills and competencies delivering 1 or 2 babies on average per week, and sometimes going several weeks at a time without delivering a baby at all. The hospital has had significant difficulties recruiting physicians, obstetricians, anesthesiologists, neonatologists, nurses, and the other clinicians that attend childbirth. And that's directly related to the low volume. I mean, these professionals know that they need to maintain their clinical skills and competencies and that they can't do it in a unit that has so few births. They also know the risks that come along with delivering a baby in a unit that delivers less than 100 babies a year. So that's been a challenge. The recruitment difficulties that are tied to the low volume have also led to significant issues with call coverage, and they've made it really difficult to keep that unit open and open on a consistent basis. It's these reasons that caused Windham to make the difficult decision to close the unit in the interest of patient safety. That unit, as you know, and we'll talk, I'm sure, a lot about today, was suspended back in June of 2020. And this was done due to issues with, staffing challenges at that point that were insurmountable. But at that point, a plan was put in place to ensure that all of the women who were seeking their prenatal care at the Windham Women's Health Clinic, as well as, any women who were presenting to the Windham Hospital ED and were able safely delivered their babies at higher volume OB units in the area that were better equipped to handle complications that can arise unexpectedly during childbirth. And the plan, you're going to hear this today, like the plan has been tested and it works. More than 100 women since June of 2020 from that program have safely delivered their babies at Bacchus and other hospitals using the triage and transfer plan that's in place and the transportation that's provided to those who need it. You are going to hear later today, I'm sure, from members of the public who are going to say that closing the Windham Labor and Delivery Unit makes it less safe for pregnant women and their babies, when I would say the exact opposite is true. Women who've historically delivered at Windham, including women of color, who we know are at greater risk for the underlying health conditions that cause pregnancy complications, are now going to have access to safer obstetric care and higher volume units with more of that ancillary clinical support staff that's needed to safely deliver babies. We want OHS to understand that this is not about taking healthcare services away from a vulnerable patient population. It's about ensuring that these women and their babies get the best possible obstetric care at facilities that are well equipped to provide it. It's important to note, and I'm also sure this is going to come up today, Windham is not proposing to terminate its prenatal care services. It's not proposing to terminate its postpartum services. Those services have been provided for a very long time. They've continued through this service suspension. They've been enhanced, things that Ms. Hanley will talk about later today. The hospital is also not curtailing or closing women's health services. The hospital itself is not closing. There's a tremendous amount of misinformation out there, and we want to make sure that OHS understands the scope of the proposal, which is limited to labor and delivery only, because those deliveries can no longer be done in a safe and consistent manner. I'm going to introduce to you today the physicians and administrators who will testify. You're going to hear from a physician from the Windham community, one from the Hartford Healthcare System, and an independent obstetric expert who all agree that the Windham Labor and Delivery Service needs to be closed. They're going to testify from their experience, and they're going to tell you why the proposal is necessary, how they believe it ensures access to labor and delivery services, and how ultimately it's going to improve the overall care, quality of obstetric care in the area. So with that, I'll introduce the group, and then I'll turn the presentation over. We have with us Dr. David Calla, and I don't know, Melissa, if you get, we'll pan in once they start to testify so you can see them. Dr. Calla is the Regional Medical Director of Women's Health Services for the East Region of Hartford Healthcare, and a physician with OBGYN services in Norwich.
Okay, can you just please raise his hand just so I can tell where he is there? Okay, thank you.
Yeah, you can start spanning, yep. And then we have Dr. Adam Borgita. Dr. Borgita is the Chief for the Department of Obstetrics and Gynecology and Director of Women's Services at Hartford Hospital. It's Dr. Borgita to my left. We have Dr. John Rodas, who is the President of Arista Health and the former President of St. Francis Hospital and Medical Center and Trinity Health New England, as well as a former practicing OBGYN. Dr. Rodas is next to Dr. Calla over here. And then to my left is Donna Hanley, Senior Vice President and President of Hartford Healthcare's East Region. And they'll introduce themselves as you swear them, and we'll pan the camera in so you can see them better when they testify.
Okay, well, so I'm going to swear them all in now. I know all four have pre-filed testimony on file in the CON portal. Can pan the camera out so I can see all four of them, please? Thank you. Could you all please raise your right hand? Do you solemnly swear that the evidence that you're given this matter is the truth, the whole truth, and nothing but the truth to help you God?
I do.
Okay, and if I could have you each to the far right, starting with, I believe it's Dr. Rodas, just state your name for the record, spell your last name, And you can adopt your, state whether or not you adopt the testimony that was pre-filed.
Yes, my name is John F. Rodis, R-O-D-I-S. And I'm the president of Arista Healthcare LLC, and I adopt my pre-filed testimony.
Okay, and then I believe, is it Dr. Calla? Is that who's next to you? Okay,
Yes.
Dr.
Good morning. I'm
Good
Dr.
morning.
David A. Calla, K-A-L-L-A. I'm the Regional Medical Director of Women's Health Services in the Eastern Region of Hartford Healthcare, and I adopt my pre-filed testimony.
Thank you. Over to Dr. Brogida, please.
I'm Dr. Adam Borgida, B as in boy, O-R-G-I-D-A. I'm the Chief of Obstetrics and Gynecology at Hartford Hospital, and I adopt my pre-filed testimony.
Okay, and Ms. Hanley?
Yes, good morning. My name is Donna Handley, Handley. I'm the president of Windham Hospital in the East Region, and I adopt my pre-filed testimony.
Okay, great. Now, when you all do take your, do speak for the applicant, please, you'll need to restate your name again. And any kind of acronyms you use, please define them for the benefit of not just me, for the public and for clarity of the record. And Attorney Fusco, I will turn this over to you.
Okay, and our presentation is going to begin with Dr. Calla's testimony. So I will turn it over to Dr. Calla, if we can zoom in.
Good morning, Attorney Yando, and members of the OHS staff. As I said before, my name is Dr. David Calla, and I'm the Regional Medical Director for Women's Health Services in the Eastern Region of Hartford Healthcare. I thank you for the opportunity to testify in support of this certificate of need application for the closure of Windham Community Memorial Hospital's inpatient obstetrical service. In my current role as the Regional Medical Director of Women's Health Services, I oversee quality and safety for women's health, OBGYN, in the East Region, including the Windham Women's Health Clinic. I'm also an attending physician at Bacchus Hospital, and I want to point out that I am also a private practitioner. My private practice group, OBGYN Services, out of Norwich, Connecticut, has played a critical role in sustaining OB services for several years before it became too great a burden for our coverage obligations. I've been in practice in Norwich since 1987. My focus today will largely be on issues with staffing and coverage that led to the decision to suspend Windham's OB service and to seek approval from the Office of Health Strategy to close that service. Essential to the provision of safe, high-quality, coordinated obstetrical care is the ability to maintain consistent physician-provider complement to cover deliveries. This complement includes, of course, an obstetrician who delivers the baby, as well as other physicians to cover 24/7, 365 days a year. And there are other critical clinical professionals who make up the team for a pregnant woman and their babies. These include nurses, anesthesiologists, and neonatologists. Delivering babies is really a team sport. Everybody has to be functioning at their best capacity to do this safely. When we have a critical situation in an obstetrical unit, it's sort of like our Super Bowl. Everyone has to be prepared and have to be working really well together. And one of the problems at Windham is that with so little volume and so few deliveries, it's really like we only have practice, but we never have games to prepare for that Super Bowl. And that really is a lot of the safety issue there. The declining birth trend at Windham has negatively impacted the hospital's ability to recruit obstetricians to work at the hospital and to recruit private practice groups to the area. It has also impacted Windham's ability to secure coverage physicians, anesthesiologists, and neonatologists, and to recruit and retain nurses and other clinicians that are needed to safely staff an obstetrical unit. Patient volume has declined significantly over the past 6 years, making it impossible for the hospital to continue to provide these services in a safe manner. The number of deliveries at Windham Hospital has declined from 376 in 2014 to just 58 births through May of the fiscal year of 2020. So that's from October 1st through May. This is the lowest number of births at any hospital in the state. In 2015, Mansfield Obstetrical Group, which is a private practice in the Windham community, stopped delivering babies at Windham due to call coverage concerns at the hospital. The practice transitioned its deliveries to Manchester Memorial Hospital, where the doctors in their group could share call coverage with other obstetricians in a large group called Women's Health Connecticut. This allowed them to have significantly less call obligation. As a result, women from the Windham community who are patients at Mansfield OB/GYN now deliver their babies at Manchester Memorial Hospital as opposed to Windham. Between 2017 and 2020, in other words, until there was a interruption in the service at Windham, approximately 46.7% of the deliveries originating from the Windham Hospital primary service area were taking place at Manchester Memorial Hospital, and only 16% of them were delivering at Windham. After Mansfield OB terminated its participation in obstetrical services, the hospital contracted with locum tenens physicians for deliveries and call coverage. Locum tenens, by definition, are a short-term solution to fill a temporary gap in coverage. They are not a good long-term solution because this type of staffing doesn't provide good continuity of care or a consistent team of providers. It's sort of like, getting back to my sports analogy, if you were trading your players every week, you wouldn't play as well. In 2016, the hospital hired Dr. Rosenstein for primary OB delivery service coverage. The hospital also contracted with my private practice, OB/GYN services out of Norwich, to provide supplemental call coverage. We then notified the hospital in 2019 that we would be terminating that contract because providing call at both Bacchus and Windham was putting too great a strain on our physicians. In January of 2020, the hospital contracted with individual physicians from my group to provide supplemental call coverage. However, this coverage was never sufficient to cover vacation and paid time off for Dr. Rosenstein, leaving the hospital vulnerable and necessitating several interruptions of service early in 2020. The hospital exhausted all options for call coverage, including reaching out to other obstetrical practices that service the Windham area, including Mansfield OB. Despite its best efforts, the hospital's been unsuccessful in recruiting and maintaining adequate physician and nursing resources to staff the obstetrical unit due to the low and declining patient volume. Since the OB unit was suspended in June of 2020, the hospital's main focus and priority has been on providing high-quality prenatal and postpartum care, as well as preparing women for safe delivery of their babies at the hospital of their choosing. The hospital has carefully planned for and executed the safest and least disruptive transition for women in the community and their families and support network. This includes planning for emergency deliveries, transportation, and emergency medical service coordination. Since the OB service interruption, there have been 102 deliveries of Windham Women's Health Clinic patients. Of these patients, 91 delivered their babies at Bacchus Hospital, an additional 5 women delivered at Hartford Hospital, 1 delivered at the Hospital of Central Connecticut, and 1 at Manchester Memorial Hospital. 4 other patients delivered at hospitals outside of our network. Looking at the women who delivered or received emergency care at Bacchus, approximately 71% were able to arrive by car, with less than 20% requesting ambulance transport. All babies born to Women's Health Clinic mothers were safely delivered at their hospital of choosing. As a practicing obstetrician, I'd like to reiterate that patient safety is of the utmost importance and foundational to the informed decisions regarding whether to continue an OB service. The decision to terminate OB services at Windham Hospital was driven by patient safety and our inability to ensure safety in a low-volume hospital. The hospital continues to engage in thoughtful and deliberate planning to ensure that each patient's care is safely coordinated. Thank you again for this opportunity to speak in support of the CON application for the closure of Windham Hospital's inpatient obstetrical service. In my professional opinion, this is the right choice for patient safety in that community. I'm available to answer any questions for you once our presentation is concluded. Thank you.
Our next witness is Dr. Adam Borgita. Dr. Borgita.
Good morning, Attorney Yandao and the staff of the Office of Healthcare Strategy. My name is Dr. Adam Borgita. I'm the Chief of Obstetrics and Gynecology at Hartford Hospital. And I'd like to take the opportunity to talk about this CON application for the closure of obstetric services at Windham Hospital. For the past 7 years, I've been the Chief of the Department of Obstetrics and Gynecology and the Director of Women's Health Services at Hartford. In my role, I'm responsible for ensuring the health and safety of the women delivering their babies at Hartford Hospital, and ultimately I'm responsible for oversight of the safe operation and continual development of appropriate and necessary health services for women in our community. Clinically, I have practiced maternal fetal medicine in Hartford Healthcare for the past 17 years. Prior to coming to Hartford Hospital, I spent 22 years in the University of Connecticut system, including my undergraduate and medical school education, my residency and fellowship, and I spent 8 years on the full-time faculty at UConn Health. And I am currently a professor of obstetrics and gynecology at the UConn School of Medicine. Having grown up in Eastern Connecticut, even spending time in my OBGYN residency at Windham Hospital, I believe I bring a unique perspective to the current situation at Windham. My focus today will be on the factors that drove the decision to terminate OB services at Windham. These include declining patient volumes, the hospital's inability to put together the physician, nursing, and ancillary clinical staff coverage required to operate a safe labor and delivery service, and the hospital's decision also to engage a third-party expert, Dr. Sindhu Srinivas, to review the Windham OB program and make recommendations about whether it should be closed and how any closure could be carried out. I will discuss the considerable efforts made by Windham to keep the OB service open, the factors that eventually required the hospital to make the difficult decision to suspend the OB program, and how Windham went about closing the program. As you've heard from Dr. Calla, there's been a significant and steady decline in births at Windham Hospital, coupled with an increasing difficulty maintaining adequate clinical staff for their OB service. This was largely driven by the decision in 2015 of the only private OBGYN group at Windham to make Manchester Memorial Hospital their main site for obstetrical care. It's important to state that group and the prenatal clinic at Windham continue to provide obstetrical care in the Windham region even at this time. However, the declining number of births at Windham led the hospital to begin exploring the possibility of closing the unit as early as 2017. In 2017, Windham engaged Dr. Sindhu Srinivas, a practicing obstetrician, an MFM specialist, and the director of obstetrical services at the Hospital of the University of Pennsylvania, to conduct a review of the hospital's labor and delivery services. After thorough review of the hospital's labor and delivery services, Dr. Srinivas ultimately recommended that Windham Hospital close their OB unit due to a decline in delivery volume, making it increasingly difficult to have facilities and personnel ready for unpredictable obstetric emergencies and catastrophic events, calling into question the safety of the unit. She concluded that the presence of higher volume hospitals within a reasonable distance created the ability to have a sustainable and safe transition for women then delivering at Windham. To review, the main reason Dr. Srinivas cited was a concern that the low volume at Windham was risky, especially for high-risk pregnant patients in this region, who have a greater risk for both higher maternal and newborn adverse outcomes. It would be safer for these patients to deliver at a higher volume hospital, who deal with deliveries and emergency situations on a regular basis, not a few births a week. Notwithstanding Dr. Srinivasa's recommendation that the OB unit at Windham be closed, Windham and Hartford Healthcare continued efforts for another 3 years to piece together an obstetrics program due to the desire to maintain services for women in that community. During the community meeting that occurred in the summer of 2020, which was held online due to the COVID crisis, I heard several suggestions from those in the community, including redeploying HHC or Hartford Healthcare System resources to fill gaps in clinical coverage at the OB unit in Windham, obtaining coverage for the OB unit from UConn's Family Medicine Residency Program, coverage from a group at Day Kimball Hospital, and locums tenens coverage. None of these solutions are tenable. There are no employed OBGYN groups at Hartford Healthcare to deploy to Windham. All the groups at Hartford Healthcare are in private practice. They choose the hospital where they wish to deliver their patients. There's no feasible way to have UConn residents practice obstetrics from their home base in Farmington or Hartford. Work hour restrictions make this impossible, and they require 24/7 supervision. The possible sharing of call with other local groups is also impossible when all groups in the region are having difficulty recruiting and covering their primary hospitals at this time. And finally, locum tenens, as Dr. Calla pointed out, was used at Windham, but by definition, this is temporary and can't meet the long-term needs of the community due to low volume, creating issues with safety and recruitment of providers. Ultimately, a committee convened by Hartford Healthcare's East Region leadership to review and make recommendations on whether the OB unit should be closed determined that it was not possible to provide OB services at Windham in a safe and consistent manner for the following reasons. Physician staffing was critically low with no ability to cover needed time off, causing periodic interruptions in service. The loss of a physician for call coverage resulted in 5 obstetricians covering both Bacchus and Windham Hospital. The nursing staff was critically low as well, despite efforts to recruit additional staff. Resignations and retirements of nursing staff resulted in 10 open shifts per week. And with 2 births per week on average, clinical staff did not have the opportunity to exercise their competencies with sufficient frequency to maintain and ensure a safe and effective program. In suspending the OB unit and planning for permanent closure, Windham Hospital followed all of Dr. Srinivasa's recommendations, including communication with the community and patients, creating a seamless transition with delivering hospitals, having 24/7 emergency transportation available, having a planned transportation service to assist women in traveling to their delivery hospitals. And Windham Hospital also consulted with the facility licensure staff at the DPH before implementing the planned suspension of services. With all the community focus and concerns on what they perceive to be negative, I'd like to touch briefly upon the positive impact and the suspension of OB services at Windham with the redirection of pregnant women from the prenatal clinic at the hospital to places of higher volume for their deliveries, such as Bacchus. These hospitals have volume and resources to ensure the highest quality of obstetric care and the safest possible outcome for mothers and their babies. As shown in the submitted documents, most women who receive their prenatal care at Windham Hospital's Women's Health Clinic are giving birth at Bacchus Hospital in Norwich. The travel distance between Windham and Bacchus is not an unreasonable distance for women to travel to deliver their babies, even factoring in the lack of highway access in the area. The trip is less than 20 miles and approximately 25 minutes driving distance, and in an ambulance, it would take even less time. Women routinely travel these distances and farther to deliver at hospitals across our state. Lastly, it's worth noting that this closure will not result in increasing costs for pregnant women. A vast majority, 82% of the women delivering at Windham were Medicaid patients. Medicaid reimburses Connecticut hospitals on behalf of patients the same rate for deliveries with some adjustments depending on wage index and other factors. In the adjustments, both Bacchus and Windham receive the same payment for obstetrical services with no out-of-pocket costs for the patients. And the addition of transportation for women to Bacchus from to the hospital they're choosing or Bacchus, whether by ambulance or other means, is free of charge to the patients. Thank you again for the opportunity to speak on support of the CON application for closure of Windham Hospital's obstetrics service. Closure of this service and the redirection of women to higher volume hospitals such as Bacchus Hospital for the deliveries is in the interest of patient safety and will lead to the best possible outcomes for all the women of Windham and their babies. For these reasons, I respectively request that you approve our CON request, and I'll be available after for questions.
Thank you, Dr. Borghetti. So our next witness is Dr. John Rodas. Dr. Rodas.
Good morning, Attorney Yondo and members of OHS staff. My name is Dr. John Rodas, and I'm a healthcare consultant with Arista Healthcare, LLC. I'm a former practicing OBGYN, maternal fetal medicine specialist, and a hospital administrator. Thank you for the opportunity to testify this morning in support of the certificate of need application for the closure of Windham Hospital's OB labor and delivery service, obstetrics labor and delivery service, excuse me. I was asked by the leadership at Windham to review the circumstances around the proposed closure of the hospital's OB unit. I've done so, and for the reasons I will discuss today, I agree that the obstetric service at Windham should be closed and patients should be delivering at higher volume OB units in the area to ensure patient safety. By way of brief background, I've been in the healthcare landscape in Connecticut for over 35 years. By training, I'm a board certified OBGYN and fellowship trained in maternal fetal medicine, high risk pregnancies, and clinical genetics, and hold a second board certification in maternal fetal medicine. I spent 17 years at the University of Connecticut Health Center, where I served as director of the OBGYN residency program, director of perinatal genetics, and where I was an active member of the Division of Maternal Fetal Medicine. I went to Stanford Hospital in 2001, where I became the chairman of OBGYN. And of pertinence to today's testimony, just before I got to Stanford, Stanford Health had bought St. Joseph's Hospital in Stanford, which was a full service hospital at the time. They bought it from the Diocese of Bridgeport and actually repurposed that hospital into an ambulatory center, closing the OB unit at that time. I should point out that St. Joseph's Hospital is about 15 to 20 minutes from Norwalk Hospital, Greenwich Hospital, and Stanford Hospital. I came back up to the Hartford area in 2011, where I became the chairman of OBGYN at St. Francis Hospital, a 600-bed level 1 trauma center here in Connecticut, the third largest hospital in the state, and the largest Catholic hospital in New England. In 2015, I became the president of St. Francis Hospital, only the 8th president in its 130-year history. And in 2017, I took on the added responsibility of overseeing Mount Sinai Rehab Hospital, and the only inpatient rehabilitation hospital in the state of Connecticut, as well as oversight over Johnson Memorial. Again, of relevance to today's testimony, Mount Sinai Rehab Hospital used to be Mount Sinai Hospital, a full-service hospital in this state. When I was a fellow here, we delivered babies at Mount Sinai. That hospital also was repurposed and became an inpatient rehab facility. The OB services were shut down. Mount Sinai is also about 20 minutes from St. Francis or from Hartford Hospital. So again, my point is I have experience with hospitals that used to provide OB services and no longer do, and know that there was no detrimental impact for the people of those communities. Also importantly, Johnson Memorial Hospital, which I had responsibility for, is in Stafford Springs, a rural community, if you will, and of a low population density. That's in Tolland County, which is just adjacent to Windham County. And just for the record, that hospital, Johnson Memorial, is a 92-bed hospital. So again, a small community hospital. Also, importantly, I've never worked for Hartford Healthcare or any of its affiliates, having in fact worked for Hartford Hospital's primary competitor, St. Francis, for many years. Nor am I being paid for my testimony today. I have neither asked for nor received any remuneration for today's testimony. And in giving my opinions today, I do so without bias and utmost respect for my OBGYN colleagues in the Windham area, many of whom I've trained and have had professional relationships with for many years. My focus today will be on several things. First, the low volume of births and staffing challenges at Windham and how that supports a decision to close the OB unit. Secondly, the demographics of patients in the Windham area and their increased risk for complications of pregnancy that necessitate delivering in an OB unit with sufficient volume to ensure staff competency. Thirdly, the adequacy of Windham's plan to transition patients to better staffed, better equipped, and better prepared high volume OB hospitals in the area, and the benefits to patients of delivering their babies at high volume hospitals. And fourth, the investments made by the hospital in the Windham community that benefit women and the vulnerable residents of that community. First, let me address the correlation between obstetric volume and safety, specifically as it relates to the Windham program. As you've heard, between July of 2018 and June of 2020, there were 2 periods of time where the OB unit went longer than 14 days without a maternity admission, and 16 periods of time where the unit went longer than 7 days without an admission. A unit with approximately 2 births per week on average, which has been known to go several weeks at a time without a single delivery, is not a unit that can ensure patient safety. I believe Dr. Calla already addressed the aspects of this, the team sport, if you will, of delivering a baby. Also, as Dr. Calla testified, OB units require highly skilled, competent, experienced practitioners who can handle the unexpected. Approximately 5 to 10% of low-risk pregnancies experience delivery complications. Complications such as fetal distress, shoulder dystocia, obstetric hemorrhage, all obstetric emergencies. When these deliveries go wrong, they do so quickly, and it's crucial that there be an available, competent staff to respond. Low-volume obstetrical programs are a safety concern, even for low-risk pregnancies, and particularly when you have a demographic of patients who are more likely to experience underlying chronic conditions of pregnancy, such as the Black and Hispanic women tend to have a much higher incidence of hypertension, obesity, diabetes, all of which increase their obstetrical risks. Hospitals like Windham in the lowest decile for delivery have the highest rate of these composite morbidities. The risk of postpartum hemorrhage is higher in rural, low-volume, non-teaching hospital units, and conversely, outcomes like mortality from peripartum hysterectomies are lower at high-volume programs. There are also concerns around the incidence of respiratory distress, diabetes, and depression in the Windham area, all of which are underlying chronic health conditions associated with high-risk pregnancies. Additionally, there are a significant number of Black and Hispanic women in the community for whom studies show higher risk of complications from obstetric hemorrhage and hypertensive disorders. Based on the foregoing, the decision to close Windham OB is the right decision for patient safety. I also reviewed the hospital's triage and transportation plan for women who historically would have delivered at Windham. In my opinion, the hospital has appropriately planned for the safest possible care for these women and has implemented its plan successfully. Indeed, experience has demonstrated that. Windham has addressed any language barriers to access for these patients and is persistent in encouraging women to ask questions if their concerns have not been adequately addressed. In addition, delivery scenarios and transportation arrangements are discussed with pregnant women early and often. These discussions begin at a woman's first prenatal visit and continue throughout her pregnancy. The hospital has arranged for ambulance transportation for pregnant women who need it. A dedicated ambulance is stationed at Windham Hospital during the overnight hours. During the daytime, an ambulance can be dispatched to transport a pregnant woman within 10 to 15 minutes from the Willimantic Fire Department that can respond within 5 minutes if needed. And whether traveling to Bacchus by ambulance with lights and sirens or by car, I believe the time and distance are reasonable for a woman in labor to travel. As Dr. Borghita testified, in fact, women all over Connecticut travel this far and further to deliver at hospitals in urban centers like Hartford and New Haven because their pregnancies are high risk, or simply because they prefer a larger hospital. During my tenure at UConn, a regional referral center for high-risk births, we readily and frequently, and most importantly, safely accepted patients with complications such as preterm labor, preeclampsia, placenta previa, triplets, and others from as far away as Sharon, Putnam, and Danbury, all more than an hour away. Lastly, there's tremendous benefit to the Windham community from the enhancements to health services that the hospital and the Hartford Healthcare East region are making as the OB service closes. This includes, importantly, notably maintaining and enhancing critically important pregnancy-related services for women in the community, such as prenatal care, lactation consulting, and diabetes management. Other services that Windham is investing in are equally important to the community. These include enhancements to women's health services, through, among other things, the recruitment of specialty physicians and investments in technology. These services and equipment collectively benefit thousands of patients and are cost-effective use of the hospital's resources. In my professional opinion, closing the Windham OB unit is the right choice for patient safety. Women will be safer delivering in local, high-volume OB units, which are better equipped to meet their needs and the needs of their babies. In addition, Windham is doing tremendous things for the community by investing in much-needed prenatal and postpartum care and other women's health services. Thank you again for the opportunity to speak in support of the CON application for closure of Windham Hospital's obstetric service, and I'm available to answer any questions that may arise. Thank you.
Thank you. And our final witness is Donna Hanley.
Thank you. Good morning, Attorney Yondo and members of the OHS staff. My name is Donna Hanley, and I'm a Senior Vice President of Hartford Healthcare and President of Hartford Healthcare's East Region, which includes Windham and Bacchus hospitals. Hartford Healthcare is an integrated healthcare delivery system whose East Region acute care general hospitals, as I said, include both Windham and Bacchus hospitals. I will repeat again that I adopt my pre-filed testimony. In addition to my role as a hospital administrator, I am both a nurse and a mother. So the issues we are here to talk about today are of the utmost importance to me. Thank you for this opportunity to testify in support of the Certificate of Need application for closure of Windham's Hospital's obstetric service. You have heard clinicians, including those affiliated with Windham, and an independent expert, testified to those factors that led to the difficult but necessary decision to request permission to close the Windham OB service. Having heard all of that testimony, which is critically important to your decision-making, I would like to now refocus the conversation and speak with you about what Windham is doing to enhance healthcare services for all members of our local community, including notably for women. These enhancements include our commitment, I cannot emphasize this enough, our commitment to maintain prenatal and postpartum services for women. This CON is solely for the termination of labor and delivery services at Windham. We will continue to care for pregnant women before and after their deliveries, providing that comprehensive prenatal and postpartum care at our Windham Women's Health Service. In addition, I will speak with you about the ways in which we have expanded other critical women's health services at Windham. We are also keenly aware of the issues faced by minorities and underrepresented individuals, and are continuously striving to advance the causes of health equity and improve health outcomes for all members of our community. There is a tremendous amount of misinformation in the Windham community around our plans for women's health services. I have heard repeatedly in various public forums that Windham is doing away with women's health services altogether and creating a health desert for women and underserved members of our community. This could not be farther from the truth. First and foremost, and as I previously mentioned, it is, I'm going to keep repeating this, that, and I want the community those who are here for the public hearing and OHS to understand that Windham is committed to maintaining its prenatal and postpartum services for women. Earlier, you heard Dr. Rodas testify to the necessity of these services, particularly in a community with a significant number of underserved women who lack means to travel outside of this area for routine prenatal visits. Prenatal visits, which are typically 10 visits in a typical pregnancy, compromise the majority of pregnancy-related health visits. Having these services available locally will help ensure that women are compliant in obtaining regular prenatal care with the goal of delivering a healthy baby at term. In addition, we are committed to maintaining and enhancing postpartum services, including lactation consulting, diabetes management, and providing these services in a culturally competent manner. In fact, I'm very excited. We have recently established a Healthy Beginnings program, which expands postpartum services to include home visits. I will discuss the details of this program in my later remarks. Windham Hospital has also made significant investments in women's health services, including the following: In September of 2020, we established the position of a regional director for women's health services for the East region. This individual is responsible for ensuring the delivery of equitable, comprehensive, coordinated, and compassionate care to Windham across medical specialties and spanning the course of their lifetimes. Windham has also added a bilingual advanced practice registered nurse and midwife at the Women's Health Clinic to help ensure proper communications and to make women for whom English is a second language more comfortable obtaining treatment. Windham is partnering with the Thames Valley Council for Community Action to fund a social worker position for the Women's Health Clinic. We have recently upgraded our mammography equipment to the latest 3D technology. We've added an all-purpose ultrasound machine to our Mansfield Ledgebrook location that will provide breast and abdominal ultrasounds for women. And we have acquired a new ultrasound machine for the Women's Health Clinic. We have also recruited additional physicians in the subspecialties of urogynecology and gynecologic oncology, which will allow women to access those specialty services in their communities and in our region. Hartford Healthcare is also upskilling and upscaling the birthing center at Bacchus to a level 2 neonatal intensive care unit. This enhanced quality of neonatal services at Bacchus will be of tremendous benefit to women from Windham who choose to deliver their babies at that hospital and find themselves in need of critically important services. Approximately 89% of Windham Hospital's health clinic patients deliver at Bacchus Hospital. Note also that Bacchus has been recognized as a baby-friendly hospital through the World Health Organization UNICEF Baby Friendly Hospital Initiative. In addition, Bacchus was recently named the most socially responsible hospital in Connecticut by the Lown Institute, a healthcare think tank that measures hospitals across categories, including equity, value, and outcomes. As I mentioned previously, we have also established the Healthy Beginnings program. It's a postpartum home visit program. The Healthy Beginnings program involves a mobile postpartum visit with a Windham Hospital affiliated nurse and a community resource partner and educator for patients of the Women's Health Clinic, modeled after best practice programs around the country. The goal of this program is to improve health outcomes for moms and babies, to assist in connecting families to community resources, and to provide information about the healthy recovery of moms and healthy growth and development of babies. As of October 12th, 2021, we have seen 3 new mothers and have scheduled 4 home visits. We have 7 new mothers scheduled for the month of December, 2 of which are Spanish speaking, 2 are Quiche speaking, and 3 are English speaking. 2 patients are scheduled already for January 2022, and several follow-up assessments have been scheduled. And women are offered this program as they go through their prenatal visits and sign consents for those home visits after the delivery of their babies. Joe Zuzel, who is the manager of community health at Windham Hospital, will provide additional details on this very highly beneficial program during the public comment portion of this hearing. In addition to the enhancements made to women's health services, Windham Hospital is also investing in the overall health of the community in the following ways. Windham has added 9 new providers in the last 18 months, 5 of whom are women. Their specialties include primary care, heart and vascular, oncology, general surgery, pulmonology, and a breast surgeon. Our partnership with the Center for Bone and Joint Care, Orthopedic Associates of Windham County in 2017 resulted in an additional 3 orthopedic surgeons, including a spine surgeon and 2 general orthopedists. Windham has also purchased a new SPECT-CT nuclear imaging technology and acquired surgical robotics, a Globus robot for spine surgeries, and Mako surgery in 2017 for joint replacement. The hospital opened a cancer infusion center in 2018. We have already planned improvements and enhancements to our cardiopulmonary rehabilitation center, our sleep center, and wound care. Windham Hospital has also been at the forefront of our COVID-19 community response through testing and vaccination. The hospital has partnered with local health districts to operate community vaccine clinics at various locations throughout the community. And this is remarkable. As of October 19, 2021, approximately 12,000 individuals have been vaccinated by Windham Hospital, and over 50,000 individuals, and over 50,000 in total throughout the East region. There have been more than 46,000 COVID tests administered from June of 2020 to July of 2021. We moved our testing center off campus to Recreation Park to provide more accessible testing for the Windham community. And we are sharing our COVID data with Generations Family Health Center for Care Coordination. Hartford Healthcare established an East Region Department of Community Health and added a new community health nurse. The Community Health Department in the East Region is dedicated to education, creation, and implementation of hands-on grassroots initiatives that will have a positive impact on the overall health of our communities. We've established an RX, a prescription for health program at Windham Hospital, which provides nutritionally at-risk families with prescriptions for fresh produce that come from their doctor and other healthcare providers. In Windham, the program is available at the Willimantic Food Co-op, the Willimantic Farmers Market, and the new Windham Hospital Farm Stand. Each prescription is worth $126. Lastly, the Hartford Healthcare East Region Community Health Department is in the planning process for a healthy cooking initiative that will be implemented in Windham County. The goal is to identify individuals who would benefit from learning about meal preparation techniques and menu planning to assist with diabetes management. Windham provides more than $1.6 million in community benefit each year, touching more than 10,000 individuals through our programs and care focusing on health issues like cardiac and pulmonary rehabilitation, diabetes education, and more. Wyndham also supports uninsured and underinsured patients in financial need with close to $1.4 million in financial assistance provided each year. You will hear in the public portion of the hearing this afternoon many unsubstantiated theories about Windham Hospital, including that the hospital is closing. This is simply not true. Based on the foregoing investments, it is apparent that Windham Hospital is not closing, but rather the hospital is committed to the Windham community and is making every effort to improve and enhance equitable access to and the quality of healthcare for area residents. The investments that Windham Hospital is making in healthcare to benefit the local community are a testament to our commitment to keeping the hospital as a vital community healthcare resource. While we had to make the difficult decision to terminate obstetric services to ensure the health and safety of women and their babies, we will continue to provide exceptional prenatal and postpartum care to these same women and children once they have safely delivered at Bacchus or the hospital of their choosing. And we will care for these women and their families throughout their lifetimes as we continue to grow and enhance access to the high quality healthcare services in our community. I thank you for the opportunity and the time to speak about Windham Hospital's commitment to provide the highest quality care to the community. I urge OHS to approve our CON request to terminate OB services. I am available to answer any questions that you have. Thank you.
Thank you. Attorney Fusco, anything else?
No,
I'm
that's-
sorry, and now I'm calling you Attorney, I'm just gonna call you, it's
That's
Fusco
right.
Groves, correct?
Fusco's fine.
Yeah.
No, that concludes our presentation. Thank you.
Okay, we do have questions from OHS staff. You'll find me either following up on some of their questions, and I will have questions to follow theirs also. With Mr. Carney and Mr. Wang will be asking a lot of the questions we had going through the documents that have already been filed. So the witnesses here are already sworn in. Of course, what happens at public comment, and I know Ms. Hanley made reference to what we're going to hear at public comment. And of course, until we don't know what we're going to hear at public comment. And it will be, the public that signed up, and it will be limited. These are not witnesses if, as far as we take into the public's concerns, as far as any other witnesses, OHS, that Windham Hospital has, I believe she was talking about those types of witnesses. And Attorney Fusco Groves, are there other witnesses that you have? I heard reference to names.
Are you talking about people who are available to answer questions?
I know that Ms. Hanley's made reference to one person, so I didn't know who else you have
Oh, yeah.
available.
Absolutely. So we do have, others we have who could answer questions include Joe Zuzel, who's in charge of community, correct? Dr. Tom Gilmore, who's the director of the Windham Emergency Department. You met Jackie Hurl, who's on. She's the attorney for HHC. I believe Sarah Lewis is available. Sarah's the VP of Diversity and Inclusion for Hartford Healthcare. And then I think Tony Mastriani is on as well. He's a VP of Finance for the East Region. And Donna can address some of those questions, but if we need him to contribute, I think that's it, right?
Dr. Mary Barry.
Oh, Dr. Mary
Dr.
Berry
Mary Barry.
from the Windham Board, correct?
Correct. She's chair of the Windham Board, East Region Board.
Oh, I'm sorry, and Paul Pidchenko, who I can see up there, who is, what's Paul's position? EMS coordinator for the system.
Okay, so our OHS staff will either, if they don't direct it to a specific, because they may know which specific witness they want to ask the questions to. If not, counsel, if you could just guide them to who would be the best, and if they need to ask the same question to a few witnesses, that would be fine. Any other witness they're going to ask of the ones you mentioned, they would have to be sworn in.
Okay, understood.
Okay, Mr. Carney, go ahead.
Okay. The first set of questions revolve around access to services within the region. Wanted to just begin by sort of confirming when was the last delivery? When did the last delivery occur at Windham Hospital? I'm thinking it's in June of 2020, but I was looking for an exact date.
It is correct. It's in June of 2020. I'm sorry, I don't have an exact date. I believe it was around the 15th or 18th.
This is the court reporter. If people could
Yes.
just identify themselves.
I'm sorry, this is Dr. Calla.
Thank you.
Correct. And ongoing, yes, because not just for the public, but this is being transcribed. So we will, for anyone who's speaking or answering a question, will need to identify themselves before they answer.
Okay, this is Brian Carney again from OHS. I'd really like you to provide me an exact date for the last, when the last delivery occurred.
Brian, this is Jen Fusco. We're looking for it
Okay.
now, so we should be able to get it for you.
Right, and what you will find also, we may be looking for late filed exhibits. As OHS goes answering their questions, we may find through answers or maybe an answer isn't complete, that we need additional documents. So we will have a list of late filed documents to be provided to us. We will go over the list at the end of the hearing. And I will issue an order for those late filed exhibits, but you also will want to keep an ongoing list of those documents that you'll need to provide if they come up.
Okay, thank you.
So in coordination with that, I wanted to just double check to make sure that the obstetric volumes that you've provided us are all up to date. So I'm looking, it seems like 58 deliveries occurred in fiscal year 2020. So I just want to make sure we have the most up-to-date volumes. I'm assuming no other deliveries occurred post June 2020. So I just want you to confirm that we have those up-to-date numbers.
And this is Jen Fusco. I can confirm, and we can look for that now. Those numbers may have been through the end of May. So there may be a few additional ones from early June, but we'll get you that exact number as well.
And the fiscal year, July 1 to the following July 1, is that correct?
No, it's
October 1.
October 1 to September 30.
Okay, so I guess I would ask that would be a late file.
Mhm.
First, late file 1. Updated delivery volumes.
Mr. Carney, this is Donna Handley.
Yep.
Through fiscal year 2020, which ended our year ended September 20, but we suspended services at the end of June, and we'll give you the exact date of that last delivery. We delivered 64 patients through June 2020. So October 1 to the end of June, there were 64 deliveries.
Okay, thank you. Okay, Dr. Borgita states in the pre-file, Exhibit R, page 210, that Bacchus Hospital has the capacity to absorb the 100 or less deliveries happening at Windham each year. My first question is, what is the total delivery capacity of Bacchus Hospital at present?
This is Dr. Calla, and I'll help answer that. It is, I don't know that we've calculated an exact number. We've done as many as 1,200 deliveries at Bacchus in the past, so I think we can easily accommodate that number.
How many deliveries occurred at Bacchus in fiscal year 2020?
This is Donna Handley, 852.
800. All right, for the record then, what I would like you to provide would be something in writing, provide evidence to support, the inpatient obstetric capacity at Bacchus and the number of deliveries for the most recent completed fiscal year. And then I'd like you to give me some kind of a projection going forward for 3 years so that we can validate that you can accommodate the volume from Windham Hospital.
Certainly.
And when you supply these documents, if they're documents as far as where these numbers, where your information is coming from, when we write our findings, they have to be based on evidence. And your testimony, of course, is part of the evidence, but where are you getting that information from? So when you put together a chart, that's very helpful. But what is the information you're using to support the number in the charts? So if you're putting together a chart or information or a statement, please also cite to whatever information you're using to get that information.
Thank you.
Okay, I'll move on to my next question. In the second completeness letter, which is Exhibit H, pages 123 to 124, you provided the number of births for Windham Hospital's primary service area towns. And these numbers basically reflect approximately 500 births per year emanating from Windham's PSA. The second table reflects that most deliveries of patients in the PSA are occurring at Manchester Memorial Hospital, which you've mentioned, I guess it's somewhere in the 40-some% range. And Windham capturing fewer than 20%, and I think only like approximately 10% in fiscal year 20. So I know we've touched on this and specifically talking about the loss of the Mansfield OP practice, but what is the primary reason, or what are the primary reasons that Windham Hospital is capturing so few patients in the service area when there appears to be need for the service with around 500 deliveries each year?
This is Dr. Calla again. It really revolves around the fact that the Mansfield OBGYN private practice, which was doing the majority of the deliveries that occur locally from that community, transferred its services to Manchester Hospital so that patients in the obstetrical world follow their providers. They don't pick a hospital and find a provider. They find their obstetrician and go to where that obstetrician directs them. And that's why those patients have gone to Manchester. They followed that group.
Okay, so let me follow up with this question. Given Hartford Healthcare's size and presence in Connecticut, why have recruitment efforts been unsuccessful to replace Mansfield OB practice in the area?
First of all, this is Dr. Calla again. Recruitment in general in the world of obstetrics and gynecology is extremely difficult. My practice based in Norwich is in continuous recruitment mode. And we have recently, hopefully have someone coming next year, but that's the first new person we've been able to recruit in 7 years. And that's at a higher volume hospital with a more reasonable call schedule. It's just very difficult to do that. You would have to recruit an entire group to come and function in an environment that's also very low volume.
Yeah, this is Dr. Borghita. The other issue is that the group that was delivering at Mansfield in Windham did not go away. So to recruit another practice, it would still have to share that patient volume with the group still in the region that's taking their deliveries to Manchester. So it would be really untenable to think you could get a whole practice to not support the entire volume of patients that could potentially deliver at Windham.
Just to follow up on that, Dr. Bagita, why did the Mansfield group leave Windham to go to Manchester?
Yeah, I mean, I can't get into their heads exactly, but I think a lot of it had to do with it was difficult as well for them to recruit to a low volume area. And when they went to Manchester, their call coverage was arranged with another group at Manchester. So they went from 1 in 3 or 1 in 4 calls at a time, every third night, to now they're doing every 10, 1 in every 10 nights. So their life became much better.
Okay, so you sort of, the way you preface that, it sort of sounded like speculation, but I'm just wondering, what was the reason you were told that they left?
Yeah, I think it was both of those reasons. Hard to recruit to the area, and the call coverage was a vast improvement by joining with another group in Manchester for call.
And this is Dr. Calla, and I did have some not in-depth conversations with one of the principals in that group, and those were exactly the reasons that he cited to me. The ability to have call coverage and better call coverage, and the potential to be able to recruit better at a higher volume hospital.
This is Donna Hanley. I have a document of notes I took in a conversation with Dr. Gildersleeve, who is the head of the Mansfield OBGYN group, back on, it was October 8th of 2019. And there were a number of reasons. One was the call. And for OBGYNs, as a second call, in case a second woman would come and be in labor, and there were 2 deliveries happening at the same time. So they were essentially either first or second call every other night. Another factor for Dr. Gildersleeve and that group's decision to leave is the inability for them to do what's called VBACs. And I don't want to step into our esteemed physicians in the room, but those are vaginal deliveries following a C-section. So it's a woman who had already had a cesarean section delivery. And a vaginal delivery after a cesarean section is a higher risk procedure. And given the low volume of deliveries, our anesthesiologists who cover Windham Hospital and provide services there were uncomfortable because it was a low frequency or low volume procedure. And so they were not allowed to perform those at Windham Hospital because of the risk, not just to the patient, but to the physicians who were providing the care.
This is Dr. Rodas. I'll just chime in if I can, Attorney Yondo, because I also spoke with Dr. Gildersleeve at that time when they were considering moving, and I got into, as Dr. Burgett alluded to, their heads a little bit. I think the call issue is, and I agree with everything Donna just said, but the call issue is significant in that it's not just that, and physician burnout is a real thing, right? It's a particularly real thing now, but it was always been a real thing. Every third night isn't really every third night, as Dr. Borghese said, because if someone's on vacation, someone's sick, someone's on maternity leave, it could be every other night for an extended period of time, which for old timers like the three of us who trained we trained at a period of time, and I trained these guys, so I know that we work 110 hours a week in training. Residents today are brought up in an era where there's work hour restrictions, and I'm not criticizing that, by the way. They never work more than every third or every fourth night, and to none of them, in my experience, over now 20 years of recruiting physicians, and I've built 2 practices, both in Stanford and in St. Francis, hospital-based practices. None of them want to work anything more than every fourth or fifth or sixth night. It's untenable. So for that practice, even though they're willing to suck it up, if you will, and do that extra call, they were unable to recruit anybody who would work those hours. So as Dr. Borghese alluded to, by going to Manchester, not only did their call immediately it become half of what it was before, the ability to recruit became exponentially greater.
I think you'll see as the questions go forward, and I'll probably have more later on. I mean, one of the questions in my mind is what could Windham have done, or what could they do, if anything, to make it more attractive, to bring in groups, bring in OB groups. You know, if the Mansfield group left because there wasn't, the anesthesiologists weren't comfortable doing a certain procedure, you know, is there something Windham, would that take care of the problem? I mean, I don't know, but those are sort of the questions. And what I'm focusing on is, you know, what else, is there anything else you could do to make this a safe procedure? And of course, I mean, you know, having doctors, of course, would be, you know, key. And, but those are where you'll see some of the questions going. But I'm sorry, Mr. Carney.
It's okay.
Go ahead.
Just one final follow-up on this whole thing. So were there any other providers that sort of offered some sort of options for you to, you know, recruit, including like community-based providers? Any other options in the area for you to have secured additional physicians for running the program?
So this is Donna Hanley. I certainly can, from my perspective as the person responsible, recruit. As I think Dr. Calla mentioned in his testimony, when we received the termination notice from Norwich OB/GYNs, it was September of 19. I met with Dr. Gildersleeve. I met with the physician leadership of Women's Health. It was Connecticut, and they're larger now, Women's Health USA. And they were both very clear that their physicians were their most valued resource. And they were working where they could provide care to the largest number of patients. That they could not take away from where the patients were going for care, where we had high volumes of patients, to put a very valuable resource for delivering 1 or 2 babies per week. We did look at locums, but I was very transparent in September of 19, and I met with the nursing staff to say, we have a few months before the December 31st deadline and termination of the group-based coverage. And what was one of the important data points that I'm not sure we made clear is that one of the physicians in that group had made the professional decision to no longer deliver. So not only was a small group of physicians covering 2 hospitals, their numbers were decreased as well. And that became the untenable situation. And when we discussed locums, we reached out for locums. Never really a solution has been very well described. The nurses were very clear, and the nurses were fierce and heroic in their continued support, covering 10 vacant shifts a week so that the program could continue, that they were dissatisfied and concerned about locums because they don't know the system, they don't work as the team. And the previous and this was documented and communicated by them, that the last outcome that was of concern happened during a locum tenens assignment at Windham. So locum is really not an option for all the reasons that have been stated.
Okay, thank you. Let's move on to my next question. In the pre-file and issues submission, Exhibit R, pages 312 to 314, you provided a whole bunch of birth rates for towns served by Windham Hospital, Manchester Memorial, Day Kimball, and Bacchus. So I'm looking at the tables, and this basically has the town and the birth rate, and really not a whole lot else. So my first question is, you know, I know we asked for the birth rates, but there's nothing to go sort of with them. What conclusions can we draw from these birth rate tables that you provided to us? What conclusions do you want us to, are you making from these tables?
Brian, this is Jen Fusco. Can you just
Yep.
clarify for me again where we're looking for this? Is it in the
Yep.
hearing issues document?
Exhibit R, yep, pages 3, 12, 13, 14. It's the pre-file.
Yeah, you're on it. Just give us 1 second.
Sure.
Okay, sorry, I think we found them. I don't know, Dr. Calla, if you,
I can try to address it. I think this was in response to a request, but this just has to do with the number of births per 1,000 population of women of childbearing age. And we're looking at the primary service areas for these various hospitals. And you can look at that and try and kind of get an idea as to whether they're having a lot of babies in these towns. If you look at, although Windham has a birth rate of about 10 per 1,000, the other towns in the primary service area for Windham, Mansfield, Columbia, Lebanon, Chaplin, Coventry are all significantly lower. By contrast, if you look at the last one, which is Bacchus's, almost all those numbers are above 10. And when looking at the other hospitals, which are the other Eastern Connecticut hospitals, which you might think as being comparable or competing, if you look at the various rates, Manchester seemed to generally, if you look at those numbers, be higher. Day Kimball may be a little lower.
Okay, so you're basically asserting that the overall Windham PSA rates are lower than the other hospital PSAs. Is that sort of the general?
Looking at the numbers in these graphs, that would be the conclusion I would reach. Yes.
I could, if I
Go ahead.
I could just add, just Dr. Otis, again, just general comments regarding birth rates. Birth rate really depends a lot on the demographics of the population. Specifically, when you talk about reproductive age women, you're typically talking 18 to 45. But if you really get down to the nitty gritty, it's really that 18 to 30-year-old group that are having most of the babies. So the population demographics really depend on the number of young folks in those communities. Young folks in the community typically relate to growth in general, population growth, population moving. As you know, Connecticut is growing substantially and the births are not increasing substantially. As a matter of fact, that's true for the whole country. The only actual growth in births in this country is related to demographics and race and ethnicity, where the Hispanic population in particular, particularly immigrant population, are accounting for the bulk of the growth in births. So I think that's true for Connecticut as well as the rest of the country.
Okay, I mean, it looks like you provided just one particularly, 1 year, one static year, 2019. Do you have any idea what the trend is of birth rates in the PSA over time? Say like for the last 3 years, and what's projected based on population changes?
It's Dr. Rodas. I'll only comment, again, I could just tell you, it's a little, it's not real world right now because of the pandemic. In pandemics in general, and in world big crises like this, populations drop. People don't have children when there's a pandemic, and that was true in 1917, and it's true this last 2 years. Birth rates way down. I think now as we get out of the pandemic, there'll probably be a slight increase going back to pre-pandemic numbers. But unless the population substantially changes with new young couples moving into community, I suspect the birth rate in Connecticut will continue to be flat as our population actually is aging substantially over time.
And if I can, Brian, this is Jen Fusco. I can direct you to, in the CON application, we do have those demographics in there. And I think in the application itself that shows the birth rate for that age demographic being flat. It's page, I'm sorry, someone's grabbing it for me. It's on page, it's page 18.
Okay. I think what would be a little bit more helpful for me in these tables would be if I also saw, in addition to the rate, how that rate was calculated. So the number of births and the corresponding population.
Okay.
And then also, you know, I'd like to see like a 3-year trend.
Okay.
Brian, sorry for interruption, but also regarding the demographics, I think you did provide the age ranges, but if you could also provide the race and ethnicity breakdown.
Okay.
Thanks, Ray.
And Brian, I think if you look on page 17, we did do a 4-year trend of it's obstetric volume as opposed to birth rate, but it will show you that, and it's based on Connecticut Hospital Association's time data and all the hospitals in the state of Connecticut.
Okay, I'm taking a quick look at it. Thank you.
Okay, just want to make sure that you have what you need.
Yes.
Yeah, while you're looking, I just Dr. Rodas again, I think the important, at least to me, the important thing is birth rate is one number. They have to multiply it by the population to determine actually the number of births. So to your earlier point, even if the population, if the birth rate went up a little bit, because the population of childbearing women is relatively low, the total number of births will still be a relatively small number. And many of those women, as we already talked about, have already made decisions of where they're going for their care, because women follow their OBGYN. As I think Dr. Calla mentioned, women don't really choose a hospital to deliver at, they choose a doctor to go to, and they go wherever their doctor, practices. So you have to understand that. So even if there's another couple hundred births, well, that's not enough to really sustain a hospital obstetric unit.
Or to recruit a new practice of physicians. This is Dr. Calla, sorry.
All right, thank you. I'm going to move on to the next set of questions related to quality. So the first question is, Dr. Calla states, page 201 of the pre-file, that in order to provide optimal care for women, hospitals need to have the volume and resources to support a team-based approach to care. And I think he said that today as well. Please provide us with an explanation of sort of the relationship between birthing volumes and quality.
I'd be happy to. In obstetrics involves critical care with rapid changes of basically two patients, a mother and a baby. And to provide that care, we need to have a well-functioning, well-trained, experienced team of obstetricians, oftentimes midwives, nurses, pediatricians, and other resources such as respiratory therapy, radiology with ultrasound capability, blood banking, and sorts of things that are available differently at different hospitals, larger hospitals, because of their greater need for those services, are able to provide them more continuously and with more experience. When you're doing very few deliveries, the team that you're working with doesn't see a lot of the things that you need to know how to respond to rapidly, frequently enough to maintain that expertise. An example, we see postpartum hemorrhages not infrequently. We need to be able to respond with alacrity, and we need to have good supportive services to do that. In a hospital such as Bacchus that is doing 2 or 3 deliveries a day as opposed to 2 deliveries a month, we see these situations with some frequency. It allows all of our team members to be familiar with their roles and what to do. This leads to better quality. When you can drill all you want, it's not the same as the real thing. I hope that answers your question.
Yes, thank you. And just following up on the Srinivas report, you gave some sort of high level sort of comments about what the report stated, what the conclusions were. Did you want to share any additional sort of details that sort of backs up what you're just talking about of the quality issues related to low volume?
Yeah, this is Dr. Yeah, thanks. This is Dr. Bordita. So when Dr. Srinivas looked at the volume, she and several other researchers have looked at this and looked across the country. She has authored one paper, and I think she had 4 different papers in her report that all looked at volume and lowest volume versus higher volume institutions based on their delivery volume, showing that there was a higher risk for complications like hemorrhage, infection, and other obstetrical issues, including lacerations, in the lowest volume obstetric units, and that in the units that had the highest volume, they had the lowest complication rates from things like hysterectomy after delivery. So I think, she went through and looked at the population that is served, the volume of the population that is served by Windham, and her recommendation was due to the risks, the safety risks based on the research that's available, having such a low volume wasn't safe, especially when there's other volumes that are very close by. If you look nationally, Connecticut's a very small state with a lot of availability of higher volume hospitals for patients, that would be the safest thing for the patients in this area.
And this is,
If I could just add, this is Dr. Rodas. So at both Stanford Hospital and St. Francis actually implemented perinatal safety programs. So I'm near and dear to my heart is your question, actually. And I think I've tried to make that clear in my testimony. And I don't want to overdo the sports analogies that I think Dr. Calla was alluding to, but there's a certain cadence that you get into in running an obstetric unit. And the cadence involves all members of the team, as Dr. Calla alluded to. And that team really can't be switching positions and players on a regular basis because you're filling it with locums or temporary staff, nurses that are coming and going, doctors that are coming and going. Drilling, actually, I would respectfully disagree slightly. I think drilling is actually very, very helpful in practicing. And we all do that in the larger hospitals. We all have regular drilling practices, which then we can translate into the real world setting when they occur, just like an engine going on a plane. Pilots, Captain Sully landed on the Hudson, not because he got lucky that day, it's because they train for engine failures. If you train with a different team all the time, when the thing really happens, nobody knows where to go, nobody knows what to do, and you could easily overwhelm the system and a disaster will ensue. And I think what we're here talking about today is really trying to prevent that disaster from occurring.
Yeah, and this is Joanne Yondo. I just want to follow up on Mr. Carney's question. So, and maybe this goes to Ms. Hanley, but I know Ms. Hanley spoke about all the investments that the hospital is putting into healthcare, a new, investments regarding bone and joint care, and 3 surgeons that came on, the robotics, the investment in the robotics, cancer infusion, cardiac. So how is it that the hospital can attract the doctors and start these investments and these new programs, but it couldn't happen for obstetrics?
That is it. I'd love to answer that question. Because there is a community need and a volume of patients who are seeking those services. So cancer rates are on the increase. And, let me use, I was an oncology nurse for 20 years early in my career, so I will use cancer as the example. It is a high frequency treatment. So patients who need to travel frequently for treatments, chemotherapy, physician visits, having that care close to home is very, very important. But the rising incidence of cancer and the demand in our community necessitated, we have outgrown the infusion center that's in our Five Founders campus on the Windham campus. The numbers are rising. Orthopedics, we talked about our population aging, the need for joint replacements, surgeries, traumatic falls in the elderly. There is a high demand and need. In fact, with the 3 orthopedic surgeons we have, we are always looking for additional surgeons because the community need and the patients are there. So it's this, that's really the theme here, with all due respect. Women in our community, the 500 or so women, 400 of them have chosen to have their deliveries and their care elsewhere. Oncology, orthopedics, heart and vascular, cardiopulmonary rehab, our volumes are very high and we're responding to that community need. Physicians want to take care of patients. And the challenge we have is in a limited resource of OBGYNs, they want to be where they can contribute and provide the most care. So there's great demand. You heard Dr. Calla say he's been unable to recruit for 7 years. In both the professional journals and societies, as well as the lay press, there's constant discussion around the increasing maternal fetal mortality rate and the decreasing numbers of OBGYN residents who are coming out of training. So it's created this dynamic, and that's what's caused the issue at Windham. So when we focus specifically on this.
Yeah, this is Dr. Otis again. I want to add, if I can, Attorney Yando, to Ms. Hanley's answer. I think we can't ignore, and I've recruited lots of breast surgeons over time, urogynecologists, oncologists. The difference is the call, not just the call's not about just the frequency, but the burden of call. If you're an obstetrician on call, you're either in the hospital all night long, or you're within 15 minutes to respond to a patient. Where breast surgeons are never getting called in for emergencies at night. Urogynecologists are never getting called in for emergencies at night. Orthopedic surgeons are never getting called in. They could live in Glastonbury, they could live in West Hartford and still provide great services to that community and live wherever they want with their families. Obstetrics is different because of that burden of call. It would be the same thing as saying, let's start a trauma center in Windham. Well, you're going to have to recruit 3 or 4 trauma surgeons and they have to live or be in that community. It's just not feasible.
Is there anything as far as, so it's basically getting the doctors aren't living in the area. I mean, is there anything Windham Hospital or the applicant can do, or what have they done to try to attract, or have they done anything to attract physicians coming in?
So I'm not, I totally respect your question. And other than, working with our colleagues, and I'm looking at the physicians around the room and their network of physicians, I'm struggling to find a different way to say.
These are private. I mean, Connecticut has many OBGYNs. This is Dr. Rodas again. Many OBGYNs. These are private practices, so you can't just wave the magic wand and 3 or 4 obstetricians will present. You have to get folks who want to live in Connecticut in the first place, raise their families in Connecticut, and that's part of the reason we have challenges, frankly, because You can only go so far to say, oh, we're close to Boston and close to New York. The kids I try to recruit say, well, why don't I just live there? So recruiting in general is difficult. Then you add the added demographic of the call. And even if everything works great, the population density just isn't high enough to have a sustainable, financially viable private practice.
And this is Dr. Calla again, if I may, as Dr. Handley, Mrs.
Okay, I got
Handley,
promoted.
sorry, Donna, stated before. She did reach out to Mansfield OBGYN to see if they would be interested in coming back, either to provide call coverage or coming back to the hospital. They were not. She reached out to the Dr. Matt Seidel, who's the head of Women's Health Connecticut, which is a large group of many practices at many of the hospitals in the state, to see if any of their members would have any interest in coming to Windham. The answer was they did not. So those efforts were made. And unlike many of the specialties that Mrs. Handley spoke about, which in the current world are largely hospital employed, for, as Dr. Rodas stated, obstetricians, general practice OBGYNs in the state of Connecticut are exclusively private practice. And that's true for much of the country. So that it's not an issue of Hartford Hospital just going out and hiring people. It's enticing a private group to come. And that's a much harder proposition.
Okay, thank you.
So I just, one final question related to this topic, and it's, you know, what is the optimum level, or what is the minimum level needed to provide, you know, inpatient obstetric services at a hospital and have a quality, you know, high quality and safe program? What will be the minimum volume?
Dr. Cal, if you're asking about number of deliveries, I would go back to the consultant report that we got in 2017, where I believe she was referencing volumes greater than or more than 500.
All right, thank you very much. Move on to the next question. So in the pre-file, page 321 states that under the heading of social determinants of health, that there is an emerging body of clinical research that suggests that patients who deliver at low volume hospitals are at greater risk for certain adverse events. But I think you've touched on some of the events, and I think we've touched on some of the demographics of the primary service area, maybe being susceptible to these particular social determinants of health. Discuss the difference between low risk and high risk deliveries, and sort of in relation to that.
This is Dr. Gordita. I think, you know, there's ways, and there's a table in the report from Dr. Srinivas that kind of outlines high-risk medical conditions. So there's certain conditions like diabetes and hypertension, heart disease. Right, so those are high-risk conditions. And if patients have those conditions, many of them would probably not be delivering at Windham or any community hospital. They get referred to the tertiary centers. That's the that's the medical conditions, but there's also the obstetric conditions. So while the delivery is happening, there's the risk for hemorrhage, for infection, for lacerations, for other complications that aren't necessarily predicted by the patient's medical risk factors. So those are unpredictable. So you can't always say, well, we're going to have you delivered at a different center because we know already you're a high-risk patient. You have to be ready for even the low-risk patients, who probably 10% of them have a high-risk complication that happens in labor. And that's, I think, the concern with low volume. We've already been sending patients from the Windham Clinic to other sites when we've identified them prenatally as being too high risk for delivering at Windham, because they have hypertension, diabetes, they have a baby with a birth defect, and they come and deliver at Hartford. We've been doing that even before any of this. But it's the lower volume now, and the risk for the patients that have risk for hemorrhage, for complications that happen during labor, that, as Dr. Calla pointed out, when you don't have a good team together that works together because there's not enough experience, that's where I think you run into concerns.
This is Donna Hanley again, Mr. Kearney. when we were going through our evaluation and planning process, and I took my role in 2017, we used ACOG, the American College of Obstetrics and Gynecology Risk Stratification guidelines. So they clearly identify from the professional organization, of which all three of our esteemed colleagues testifying today are members. So we were rigorous and disciplined in assessing risk to make sure patients were provided and care coordinated so that they were appropriately delivering in a facility appropriate to the risk that has been assessed based on their individual clinical situation.
Okay, so my next question is kind of been answered, I guess. So then I was asking what the general proportion of high-risk deliveries would have been at Windham Hospital, and you're stating that basically it would be low. Is there a
Correct.
percentage you can assign to that, or it's like 10% of the patients maybe would be high risk, or hard to guess?
Yeah, I think this is Dr. Borghita. I think it's hard to guess. One is that probably 10% of the patients that presented for care there were actually getting transferred to get their care elsewhere before they even come in for delivery. And then I'd say the next 10% of who are delivering there would also potentially have high-risk complications that arise in labor.
Okay, thank you. Okay, my final question is for Ms. Hanley. You stated in the pre-file on page 297 that Hartford Healthcare is upscaling the birthing center at Bacchus to a level 2 neonatal intensive care unit, NICU, also known as special care nursery, including hiring a medical director and additional training of obstetric nurses. For the layman, please explain, what it means to be a level 2 neonatal ICU and how this will improve the quality of care for obstetric patients in the area.
So I'll let my colleague, Dr. Calla, is going to describe what a NICU level 2 is. I'm happy to, and then I can add the rest of the details around the question you just asked.
So a nursery without any sort of neonatal ICU capability generally will keep babies who are otherwise well that are 35 weeks of gestation or above, which is the vast majority of babies that deliver. But there are a number of babies that deliver prematurely, or babies who have transient issues with respiratory issues or with feeding that require higher levels of care. A level 2 NICU generally will take care of babies that are premature as early as 32 weeks gestation, and will have better capability to take care of babies from 32 weeks to term who have issues that might require short-term ventilatory support, that might have feeding issues that require additional levels of care. There will still be babies in those ranges that would still need a higher level of care for significant anomalies or things like that. There are other levels of neonatal ICU care that take care of babies that are younger, but that's not what we're discussing at Bacchus.
And one of the, this is Donna Hanley again. One of the ACOG recommendations, giving our limited resources of our most precious resource, which are physicians and highly trained nurses and neonatologists, is to look at regionalization, where you look at your population and putting the right level of care. So this is an example of this, by having a NICU, a level 2 NICU at Bacchus, and 91 of our Windham women went to Bacchus for delivery to provide that additional level of care for all the women in our region. We don't have enough physicians and nurses to staff every hospital. So this is really a nationally endorsed model, is to provide the best care to patients. So one of the limited resources we had in 2020 was neonatology coverage from Children's Hospital. And I know that the division chief of neonatology submitted testimony that they had to reach out to locum APRNs, neonatology APRNs, to help support Windham, because again, of the low volume, they were deploying their staff where there was the highest volume and the greatest need for their services. So we're working with Children's Hospital to identify a medical director who could provide that oversight for the whole region, for the Windham community and the Bacchus community.
And this is Dr. Cal again. And by trying to, in some ways, regionalize this neonatal care and expand its capabilities, it means that patients from the Windham community whose babies need special services, the vast majority of those will be able to stay somewhere that's 16 miles away, as opposed to having to come to Hartford or even further. For many end up at the hospital of Central Connecticut, as an example,
Or UConn.
or at UConn, which are less accessible to those patients than if we were able to regionalize more closely to Windham.
Thank you very much. Those are the questions I have at the minute.
Thank you.
What I'd like to do now is I would like to take a 15-minute break. We will between 2 and 3, I do plan, there's probably an hour break if we finish up. We should be finished up, before 2. But what I'd like to do now is just to take a 15-minute break. So if everyone could come back on then at 12:14.
Thank you.
Perfect, thank you.
Thank you. And please, everyone, turn off your audio. Otherwise, you will be recorded because the recording will finish. Okay. See you in 15. Attorney Fusco, are you ready?
Yes, we're here.
Okay. All right. I believe Mr. Carney had a few follow-up from his questions.
Yeah, so in regard to like other providers in the community or in the area, specifically like other like FQHCs or local community healthcare health centers. I think there's a couple in the area, maybe United Community and Family or Generations.
Yes.
Do you guys have any existing relationships with them regarding maternity or obstetrics, or is there any potential to establish relationships with those types of providers to help, keep the program running?
This is Donna Hanley. Prior to my arrival at Windham Hospital, there was a very concerted effort with Arvin Shaw and Generations, Windham Hospital. And at the time, it was back when Mansfield OB was still practicing at Windham. And there was an enormous amount of hard work, and Windham, one of my predecessors, invested and supported the project, and actually filed for CON. The CON was granted. And since I wasn't there, but Mr. Shaw, in multiple conversations with me, said that once we had approval from CON, Mansfield OBGYN said, we're not interested. And it was really a way in which to let Generations run the clinic, the prenatal service. But when Mansfield OBGYN left, there were no OBGYNs left to do that. So, and I know there's reference in Dr. Watson's testimony that was submitted, Mr. Carney, but there's conversation about the increasing specialization within obstetrics and gynecology. And it's increasingly more difficult when we think about providing the right level of care. So the bylaws, it used to be 25 years ago, family practice physicians, and maybe less time, family practice physicians delivered babies in hospitals. That's no longer the case. OBGYNs are the only physicians, other than under emergency circumstances, who deliver in our hospitals. So the ability, there aren't enough OBGYNs. We can't recruit an OBGYN. I think that's thematic in our testimony today, that there aren't OBGYNs to recruit to smaller, low volume centers. It would take at least 4 physicians to even consider covering call. And for 1 or 2 deliveries a week, that's not enough for them to have a viable, thriving practice doing what they are called to do. John?
Yeah, if I could, Mr. Carney, if I could elaborate a little bit. While I have no experience with those particular FQHCs, I have extensive experience actually with many FQHCs in this state. And I would say that virtually all of them rely actually on the hospitals and or the obstetric community near where they serve to provide obstetric services. None of them that I'm aware of in this state have been able to successfully recruit, and they've tried as well, their own OBGYNs to provide those services. And even if they can get one, that person only does prenatal care, but when it comes to delivery, they'll have the patients come to the regional hospital. FQHCs have an interesting model in that they're limited a little bit to what they could pay folks. So that's one of their challenges. They have kind of basically salary cap that really preclude them from being competitive in the marketplace. Even with the loan forgiveness program that you get potentially through the federal government, as well as you're covered for medical malpractice because they're covered, as you probably know, by the Federal Tort Claims Act, so you can't really sue them. While all that's tempting, I can tell you, at least in Connecticut, none of them have been able to recruit OBGYNs, and I've been asked by at least 4 or 5, both in Fairfield County and in Hartford County, to help them recruit. And I've said the same thing to all of them. I said, we'll provide the services for you, but you're just not going to be able to recruit.
And I would just add, Mr. Shire and I have commiserated together on numerous occasions that one of the greatest needs in our communities, and based on community needs assessment, is actually primary care, right? So
Exactly.
it's, we work very hard and it's hard to recruit primary care. And it's increasingly more difficult when you're talking about specialty care.
And this is Dr. Cal again, and I have some knowledge. You asked specifically about United Community and Family Services, which has recently become a federally qualified health center. They do have a gynecology clinic in Norwich, which is staffed by a midwife. OBGYN Services, my private group, provides supervision for that, but we've had numerous conversations about their provision of care, and they are not interested in getting into the rest of the obstetrical realm. They provide primary care, pediatrics, mental health services, and dentistry services extensively in Eastern Connecticut.
This is Dr. Borghita. Just to add on my own experience in Hartford, we have an FQHC around the corner, Charter Oak, and they provide prenatal care with, as Dr. Rodas pointed out, sort of a revolving door of providers because it's hard to keep the providers there. Midwives that come and go. All their deliveries come to Hartford or St. Francis if they choose, but they don't have providers that actually do the obstetrics, just the prenatal care. And then we return the patients back to them. So their patients are showing up, they're getting good prenatal care, but they don't able to recruit the providers to provide the inpatient care. I just wanted to add, going back to what Donna Hanley said, back in 2013, Hartford Healthcare did recruit one of the residents graduating from our residency program, the UConn program, to go and work at Windham, to run the prenatal clinic, to work. The idea was to transition over to Generations and to have Mansfield OBGYN sort of as the mentoring group to her to provide coverage. And that all fell apart when the prenatal clinic didn't transition to Generations, and Mansfield OB did not want to provide coverage for the provider. So having one provider right out of residency was an untenable situation. She couldn't work alone. And she ended up coming back and working in our clinic at Hartford Hospital. So that's the problem of residents that are graduating, that they don't want to go to a place where they're not supported. And to have the support that they're comfortable with from their training, it requires usually a level 2 nursery or some kind of on-site 24-hour care, partners that are there to mentor them. And I can tell you, being involved with the residency at Hartford, I get calls from almost every area of Connecticut looking for graduating residents to join them. And they're very, very selective about where they want to go. Almost exclusively, they go to practices that have 8 or 9 providers so that their lifestyle and their coverage and the mentorship that they get is the level that they're comfortable with. And that's, as Dr. Rodas pointed out earlier, that's what the new generation of providers are looking for. The days of 2 and 3 men group, that's gone.
Okay, thank you very much. I'm done with my questions.
Okay, I know Mr. Carney had, he named 2 of the federally qualified local health centers in the Windham area. Are there any others?
No, not to my knowledge.
Okay, and as far as as another late file, we would like some affidavits from either people that you've reached out to. I mean, we certainly appreciate all your information. And as I mentioned earlier, we always want to know where the sources come from when you give us information in charts. So if we could get statements of the doctors or and this can be done, with late filed affidavits, doctors or the Mansfield OB group or other groups that you've reached out to, that they're not willing to come to Windham.
Of course, we will do that.
I have a question and related to this. So your prenatal and postnatal care, where's that care? At what location? Where do you do that?
That's right on the 3rd floor of Windham Hospital.
Okay, and who's there? Are there doctors there?
So we have the doctor that Dr. Calla referenced, Dr. Eugene Rosenstein. He happened to be one of our locums. We engaged a firm called Delphi back in 2015. Dr. Rosenstein came, he had previously been employed by Mansfield OBGYN, and they no longer had a relationship. He worked for Delphi as a locum, came to Windham for an assignment, and because he lived locally, said he would be very interested in the role. So Dr. Rosenstein is the full-time physician running our outpatient service.
And he's an obstetrician?
He's an OBGYN, correct.
Okay,
And when he came, he did 3 nights of call, and Dr. Calla's group did the other 4 nights of call. And you've heard reference the periods during January through June of 2020, that Dr. Rosenstein had booked a number of CME weeks and vacations, and we had 3 periods of interruptions. And we realized then, given the fact that there were fewer resources from our Norwich group that had been so supportive of Windham, that we needed an additional provider. And that's when we recruited. It took a while, but we found an APRN midwife, Erin Blaine, who now works full-time along with Dr. Rosenstein, running the prenatal, postnatal, and women's health service clinics.
Was the decision ever, and he did deliveries at Windham?
He did.
Okay, and when was his last delivery?
Well, I'll have to check. We did confirm that the last delivery at Windham Hospital was June 16th. I'll have to check and can we check and make sure it was Dr. Rosenstein, please, Laura? We'll confirm whether that was a delivery of Dr. Rosenstein's or one of the Norwich group.
Okay, and then, so the women who go for their prenatal care
Yes.
at Windham Hospital, they would consider Dr. Rosenstein their doctor, is that correct?
That is correct. Or Erin is their provider, their provider. Those are the 2 providers.
The midwife and Dr. Rosenstein.
Yes.
She's not a midwife, is she?
Yes, she's more.
And are they told from the very start that they won't be delivering at Windham?
Correct. So the process we have, if you'll indulge me for 1 minute, please. I want to just give a little background into the plan we put in place. In 2017, when I assumed my role, it was a few months after we had the outside consultant in the report that Dr. Borghita referenced. A former OBGYN from Windham Hospital, Dr. James Watson, whose testimony is filed, he couldn't be with us today, was a member of the East Region Board of Directors. And he shared with me his concerns around the quality and safety and volume in the Windham OB program, and asked me within my first week to do a deep assessment and analysis. So I immediately formed a group, Dr. Borghita, Dr. Calla, other executives, the Vice President of Medical Affairs, and we had standing meetings so that I could do an evaluation and assessment of the Windham OB service. And we used the baseline. We had this recent consulting document. We looked at the most critical resources necessary to provide the right and best care for patients. It was nursing, it was physicians, OBs, it was neonatology. And frankly, we had a fragile, but we had the resources we needed, which is why, despite the recommendation in 2017 to no longer deliver, we knew that we could continue to deliver. However, any one of those critical resources or elements to provide care to patients, if anything happened to lose that resource, we needed to have a plan to care for our OB patients. So we spent close to a year developing the very robust plan that we put in place. And then we just put it away because the process and the system we had was working. So this involved detailed assessments and evaluations. And when June 20th, 20 came and we had to suspend services for the lack of physicians and RN support, we had 2 more RNs retire or resign from Windham OB. We had the plan ready to go. That includes from the very first visit, we document the conversation with the patient. We have standard and written education around the fact that prenatal care and postnatal care will be delivered. And then we engage the patient in the conversation about where she would like to deliver. If she has a hospital, a preference. We evaluate that. We talk about those typically 10 prenatal visits prior to delivery. This is reinforced and re-educated every single visit. So the patients know they go into labor, what number do they call? What are those resources? We assess whether they have transportation. 71% of the women who delivered between June of 2020 and October of 21 had transportation. They have resources. The women who do not, we provided transportation. And I think it was the percent who came by ambulance.
20.
I don't have the number in front of me. 20% by ambulance. We coordinate that. The most important part of this plan is it's individualized. It's assessed at every visit, and we make this really specialized plan so that the patient's needs are met. So it's documented, it's standard work, and one of the things that we explain to patients, when women go into labor, their OBGYN, if you think of a large center, they see their doctor at every visit. But if their doctor's not on call when they go into labor, somebody else delivers for them. And that's really what happens in this scenario. We coordinate with the receiving facility, the receiving team. They know the patient is coming. They have the medical records of their prenatal care so that it is seamless and coordinated.
Okay, and are any of those patients of Dr. Rosenstein's, do they go anywhere else than Bacchus?
Yeah, there were a few.
There were a few. So we had 5 that went to Harvard Hospital, 1 went to Manchester.
And Mr. Dr. Calla, one went to the hospital in Central Connecticut.
And those were Dr. Rosenstein's patients?
Yes.
Clinic patients.
See, Dr. Rosenstein, so Dr. Rosenstein cannot do call. He can't do 5 days of seeing patients in the office and then 7 nights of OB on call. Women deliver all hours of the day and night. So he has a clinic, if he had a clinic full of patients, he can't also be the person who delivers those women. So, Dr. Rosenstein's patients, which are essentially the patients of the prenatal service, deliver with other physicians in any of the receiving hospitals. So there's a handoff, an effective handoff.
Because I know, and I know Mr. Wang's going to talk more about the transportation. But one of the things is, the ambulance transport to Bacchus or another hospital, providing the patient has made arrangements in advance with a receiving physician on the other hospital. I mean, so if these patients are Dr. Rosenstein's, who's the patient, who's the physician at the other hospital?
Yeah, I was Dr. Calla. So if they are among the 90% of these patients who come to Bacchus, it is the physician who is on call at Bacchus Hospital. There is a clear understanding, the physician, that's part of their call responsibility at Bacchus Hospital. For arrangements to other places, we would reach out to providers at Hartford Hospital, for instance. Usually it would go through the Women's Ambulatory Health Service there, and we'd make some sort of transition. If they want to deliver other places such as Manchester, we would have to individualize that outreach to providers at that hospital.
And given their estimate, I'm sorry, this is Donna Hanley again, and we really based it on their due date. So the receiving hospital knows the appropriate day to expect this patient. We want to look at who's on call. So we use every effort to educate and communicate to our patients what to expect when they.
And this is Dr. Calla again, and as long as they're going to one of the hospitals that is in the Hartford healthcare system, which is all but very few of these patients, the electronic medical record that's used in the prenatal clinic is the same one that is visible at each of those hospitals. So the patient's records, labs, and prenatal care narrative is available readily to the physicians who take over their care when those patients come to deliver.
If I could
Manchester
add-
Hospital is not part of Hartford Healthcare, correct?
Correct. And in that case, we would make an arrangement for a hard copy of those records to be available.
Okay, has Windham Hospital had contacts with Manchester Hospital about what their plan is?
I'm not trying to think, would you mind please repeating that question?
Right, so when one of your charts, I think 47% of the deliveries in the PSA go to Manchester.
Correct.
And you have this application in front of us to terminate your services. And you have information in your application about, Manchester Hospital, and we're going to take them to whatever hospital they want to go to. Has Windham Hospital reached out to Manchester regarding their plan?
Well, I'm going to answer a little bit about those numbers. Since we've had an interruption in service for over a year, and only one of the patients in that period of time has gone to Manchester Hospital, it would not create an additional burden to them. I do know that the physicians who provide coverage at that hospital, who are the ones who are doing the deliveries, are aware of this plan because we've had conversations with Windham, with Mansfield OBGYN, and they're part of that coverage scheme. I don't know whether we've had direct communication with the hospital administration per se.
Correct. The other thing I just want to point out, Attorney, is that the 46%, the majority of those patients are already patients of Mansfield OBGYN. So when we look at the PSA and that data, we look at all of the women in our primary service area and where they've delivered. So of that 46%, a small fraction are actually the patients who are patients of the Windham Prenatal Clinic. The rest of those women have already chosen to have all of their prenatal care and their delivery at Manchester Hospital.
I know you've used the word suspension and interruption, but it seems as if OBGYN, birth and delivery has actually been, terminated at Windham since June of 2020. And so I'm just wondering how it is that the hospital in 2020 could stop those services. And if it is just a suspension or an interruption, do you have plans of going back on, or in your mind, it was terminated as of June of 2020?
So I think language is really important here, and I'll just let you know that. So we had an extension and support from several of Dr. Calla's partners to help us get from January till June, where we were attempting to recruit and locate replacement physicians to take call. When it became apparent that we were no longer going to be able to do that, the covering physicians only agreed to extend from January till June. So that's when we made the decision that we could no longer provide the service. So I called Donna Ortelli from DPH. I wanted, before we did anything in terms of activating our plan, and on June 19th of 2020, I called Donna. I explained our current state, the situation in terms of low volume, the loss of nurses, and this is in the middle of the pandemic. We lost nurses because of, first nurse resigned because she was uncomfortable working in an acute care setting, which left us in even a more compromised staffing plan. And she immediately responded when we talked about volume and resources, that this was a competency, quality, and safety issue. So she confirmed, she reiterated that we cannot stop or close the program. We cannot close the program until we have CON approval. And that's why we're here today.
But it was,
So we.
and I know we're talking semantics, you stopped the services on June 16th.
Correct. We did not deliver another baby at Windham Hospital after June 16th.
Okay. So I'm looking on, as part of your attachments, you have minutes, or I'm not sure if these are the full minutes, are part of from the Hartford Healthcare Corporation Board of Directors, minutes of meeting dated June 16th, 2020. And this is, it says 7.0 operations report, and I'm looking at Bates number 000330. And I'm not quite sure where. I think this is this came in one of the after documents. Michael Daglio reported on the plan for closure of Windham Hospital's obstetrics department. He noted that the issue had been brought to the board for awareness in November 2019.
Yes.
Mr. Daglio reviewed the rationale and plan for the closure, outlined the women's health services that would continue and be improved in the area, and reviewed the timeline and approval process. Attorney Mack recommended that the board approve the closure of Windham Hospital's obstetrics department. Upon motion duly made and seconded, it was unanimously voted to close Windham Hospital obstetrics department. So the plan for the closure, is that a written plan that's referenced in the minutes?
So maybe I can back up a little bit. I report to Mr. Daglio, who is the Chief Operating Officer for Hartford Healthcare. And I presented to our board in November. 2019, presenting the situation we found ourselves in, that we had a plan if any of these very critical resources should fail, that we were going to continue to work through the winter and spring to find additional resources, but that ultimately, if we needed to enact our plan, that we would go back to the board. I did not go back to the board. I'm very careful in my language, because we have obviously moved patients to a higher volume center where they will have the appropriate care. But we no longer had the resources to care for those patients. Despite every effort, we no longer had the resources to provide that care.
So when you talk about the plan, and the plan that you presented in 2019, is that in writing?
Well, it's everything we've submitted as part of our CON application, but we do have a plan. It's the binder,
I think there was a separate document submitted to the board to review at that meeting. If you don't know.
I don't know. I will absolutely look to see if there was a document that was submitted to the board. I did the preparatory presentation in November, and this was a follow-up to the board.
So as a late file, could we also have the meeting minutes for the meeting in November 2019? Where, and I guess it would be part of the operations report.
Yes.
Okay. All right, and just I have one more line of questions. I don't think it's Mr. Wang touched on it. But we were talking about the demographics, and I've gone through the application and all the documents, and we did a word search as far as we have the demographics of age of women in the area. There's also a chart. There's 82, I think 82% are Medicaid. Is that correct?
Correct.
So is that 82% of the women who have delivered, or is it 82%? What is the 82% on Medicaid? What are we?
Those were the 80. So that references the patients who are patients of our service and clinic.
For OBGYN?
OBGYN.
82%. Okay, and I know Mr. Wang had asked for, there's nothing in there about the makeup, even though it was asked, there was no answer on the ethnicity and race. I also see there's you talk about in Windham that and I see reference in documents about language, and I don't know if you keep any demographic information regarding, do you have part of that, the women that are serviced by Windham, is English not their first language? So
Yeah, that is documented, and all of our teaching and instructional materials around all the things I described in that previous conversation are both in English and Spanish. And if the patient has, their first language is not one of those two, we do have a translation service, ITI, that is part of the assessment for what is the language, preferred language. And then we would use that ITI service if we did not have a person who is certified in that language to come translate for that patient and provider.
okay. All right, if you could add that to the demographics, if you know, if you take
Sure.
you know,
We can break
about
that down.
the people that use the Windham services. Also, I think your age demographic was about the demographic in general of women in the PSA, and I appreciate, and that's helpful. Do you also have a demographic of the age of the women who have used the service, who are giving birth? Are they, you know, if we could have a range, are they 18-year-olds? Are they 30-year-olds? I'm just trying to get an idea of who is being impacted. You know, 82% Medicaid, you know, so low income. I don't know. Are we talking, you know, women of color? Are we talking white women? I don't know, based on what I have on the application. You know, what language are they speaking? So I think a lot of this is matters about who in the population is impacted by this. And I think we don't have enough information. So when you could put that together for me and footnote it, or somehow put, you know, where you're getting this information from. It's probably from your records or whatever,
Yes.
but we need to know not just your testimony or that you put together a chart, but where you're getting this information from.
Sure, thank you.
Okay, great, thanks.
welcome.
Mr. Carney, do you have any follow-up on my questions?
No, Attorney Yando, I do not.
Okay, all right, Mr. Wang, you can go ahead.
Thank you. Good afternoon. So Ronan Wong, Office of Health Strategy. Before I begin my questions, just one quick clarification. Is Dr. Robert Gildersleeve the primary contact for Mansfield OB and Associates? Is he the person that all the discussions were had that you had mentioned in your testimony, the prior discussions?
Yes, this is Donna Hanley. He was the chief of the department and lead of that group. And he submitted testimony as well.
Thank you. So my next two questions are regarding transportation. I know we just had some discussion and we shared some of the percentages, but the pre-filed testimony, Exhibit R, page 320, states that the hospital has arranged to cover all costs related to transportation to the receiving hospital for women and their families and other support persons. Are these covered costs available only to patients delivering at Bacchus, or will these costs be paid for patients delivering at other area hospitals?
So this is a service to all women in the prenatal clinic. So wherever the patient chooses to deliver, we provide the transportation services, but for both the patient and the family.
And just as a quick follow-up to that, how are these costs covered? I mean, what are the funding mechanisms for these transportation costs?
So Windham Hospital, we have a fund that was dedicated and restricted to women's services, maternity and rehab services. So we use those funds to support the transportation.
Okay. And I know it has been mentioned multiple times that approximately 71% of women that were looking to deliver at Bacchus arrived by car, and then around 20% requested ambulance transport. Just for clarification on that percentage, these are just percentages.
50, 60.
Okay, I think someone needs to mute their,
Mute.
Better get it. Sure, you'll be a fool if you don't, because it's
Leslie.
I got it.
Okay, so regarding those percentages, just for clarification, those are just for all patients requiring transportation, because there's 9% missing, and those 9% are those that are going to other hospitals, right? So 71% isn't of all of the Bacchus, because then there would be a percentage of people missing from that transportation assessment.
I'm not sure I really understand the question.
But he's trying to get these numbers up to 100.
You're trying to get them up to 100?
So it's 71 ambulances.
Okay, I understand. We do have that breakdown for you. Thank you. So by car it was 71% or 83 patients. We had ambulance from Windham Hospital was 15 patients, which was 13%. We had ambulance from another location. Some women called for the ambulance to home. So the ambulance went to their homes. And that was 7 patients or 6%. And we do have 10% or 12 patients with travel unknown.
Unknown, okay. And so regarding that travel unknown, is there any transportation assessment or any sort of metric on the transportation in the area for those that might not have access to a car or public transportation?
Well, we do offer our patients, we have a service as part of Hartford Healthcare, and it's called Ride Share. And it's for our patients, and that's the service we use for patients that don't need an ambulance and do not have a car. So, one of the processes we put in place, particularly when we had our several weeks of interruption before the June 2020, and then ongoing, we evaluated and studied every single patient's case, the transfer, making sure, did we have any opportunities to improve our process? We wanted to learn from every single woman's experience. And so we continue to tweak, and we never get to perfection, but we always try to do that improvement with every patient. So this for me is an opportunity to improve, to understand this 10% and how they got to the hospital for delivery. So we could do a follow-up audit. I'd be happy to do that.
Great, that'd be much appreciated. So my next question is regarding cost to consumer. The pre-file testimony.
I just want to follow up on some of the transportation questions, if I could. In your answer, you talk about transportation for the women and their families.
Yep.
So have you provided transportation for family, and how do you do that?
So it's the same process. So during the prenatal visits, we assess transportation, and we have provided the ride share, which is the process and the system I just described. It's typically just for patients, but in this circumstance, the special circumstance and the special population, we provide that to loved ones, support of the patient who is delivering. Most of these women, when it's a healthy, uncomplicated delivery, they're in the hospital 24 to 48 hours. It's just a very brief admission. So the ride share is what we use.
What if it's longer?
We continue to provide the service.
Okay, and what about bringing the babies home? Do you provide transportation for bringing the mother and the babies home?
Yeah, it's the same thing with car seats through ride share.
Okay, all right, thank you.
You're welcome.
So shifting gears a little bit to the cost, pages 324 and 325 of the pre-file testimony states that the impact to the small number of women who have commercial insurance cannot be readily determined. Despite the low volume of commercial and self-pay patients, OHS still needs to evaluate patient costs for those patients who would no longer be able to deliver at Windham Hospital. So since Windham and Bacchus are both parts of the Hartford healthcare system, we're asking for evidence to evaluate patient cost for delivery at Bacchus compared to Windham. So this could be in late file if that's something that we can receive.
And Mr. Ryan, this is Jen Fusco. That's for commercially insured patients, correct? Is that
And
what you-
self-pay. Yep,
Commercial and
self-pay.
We can get you that.
Thank you.
We have the same self-pay charity care policy at both hospitals, so we'll be happy to share that.
Okay, thank you. I'm just going to make a quick note as I'm keeping track of all the late files. The next question is just regarding financial feasibility. How will the termination of the inpatient obstetrics program impact the financial performance at Windham Hospital? And so in addition to your response, please provide an updated financial attachment A to include fiscal years 2020 through 2024 and include all assumptions.
So you're asking for late filing. I'm happy to answer some of that if you would like.
Please.
Although this was never a financial issue for us, as long as we had the resources, we continued to provide this service. And on the last year of our program being open and it's, what it was in terms of slightly under or at 100 or 102 deliveries, we did have a loss to the bottom line from this program, but we remained committed to that program. And the cost of when we look at the cost per delivery, because there were so few births and the overhead, there were always 2 nurses on every shift in case a patient should come in and deliver. So we always had 2 nurses. And as you heard, there were weeks at a time when there were no patients. The average cost for delivery, not the charges, this is not what patients were charged, but the cost of the organization was slightly over $27,000. And at Bacchus, it was slightly over $7,000 because we had more volume and it's just the way that the hospital finances work. So
All right, thank you.
we'll submit to you that the impact of suspending this service in the late filing.
Okay, thank you. And then my last set of questions, we might revisit after public comment as well, but with regard to the ones that we've received thus far, there's been a lot of concern from the public about services being reduced, suspended, transferred, or no longer being offered. You have mentioned in your testimony and commented on that as well. But at this moment, would you please discuss any services that have been suspended or terminated at Windham Hospital in addition to inpatient obstetrics?
Well, in my 4 years tenure, there have been, we have not terminated or stopped other services. We certainly can look back further, but I cannot recall any. Windham joined Hartford Healthcare in 2008. We certainly evaluated, and I have to give, as a result of the work that we have done, the year prior to my arrival in my first year, our average daily census of Windham was in the teens and 20. Today we have 47 inpatients and a very busy, full, PCU. And we have worked very hard to provide the services the patients in our community need and want so that they can have that care delivered. And it's been a turnaround for Windham Hospital. The recruitment of the orthopedics, patients will leave in the community for orthopedic surgery. So, but to my knowledge, there's none, but we will do that research.
Okay. And then just regarding future changes in services, perhaps in the form of a 5-year services plan for Eastern Connecticut or Windham. Does that plan exist, or can you discuss some of the future changes in services?
So, we talked that thing, especially after the last 18 months, 3 to 5 years is almost a lifetime because things change so quickly. But we do have a strategy and growth plan. And to be happy to, it's the investment in the SPECT CT, which is used primarily for cardiac imaging, investing in those heart and vascular services. Additionally, when we were fortunate enough to recruit the orthopods in 2016, 17, we, Windham Hospital, have created a Medicaid clinic for orthopedics, which didn't exist, and there were very few in the state, Yukon and Windham, and we were getting patients from all over the state to come to our orthopedic Medicaid clinic, just because it's rare. So I'd be happy to share that with you. It doesn't go out 5 years, but it's certainly the next 2 to 3 years.
Okay.
Expansion of our cardiopulmonary rehab, expansion of oncology services and infusion because of the demand.
So I'll add
And if
the
I could-
strategy and growth plan to the late file.
Yeah, and just to follow up on Mr. Wang's question, as part of like the 5-year plan or the strategy plan, I'm wondering too, I know what your plan is now or what you have implemented as far as transportation to other hospitals, and is that part of the plan to keep it going for 5 more years? I mean, once, what acknowledgement do we have from Windham that you're going to continue to offer, the transportation or everything you've put in now? I mean, is that in writing? Is that part of a plan?
This is the standard work. We call it standard work, which is how we care for patients. So this is the program now. So there's an absolute commitment, and we have the restricted funds to use for this service. So
When you say restricted, do you mean like reserved? When you say restricted?
It's reserved, yes.
Okay.
Yes.
Okay. I'm sorry, Roy, any more questions? Mr. Wang?
No, Attorney Yendo.
Okay, so I have just a question. So, I know Connecticut is small, but we have a lot of roads. And what I would like as part of a late file, I know you say that, you tell us how many miles, Bacchus is, how many miles Manchester, Hartford, Day Kimball. And you estimate, travel time. If we could have some sort of a late file, whether it's a MapQuest or some kind of travel, because I there aren't a lot of highways. I mean, my, limited, knowledge of roads and everything, but my understanding is I don't think there are a lot of major highways coming out of Windham. I could be wrong, but if you could supply us with maps and that distance, and I do understand, in an ambulance, it's going to be shorter. So I know, and I would take that into consideration for, all the hospitals, but I would just like something a little more scientific or a little more formal about what that travel time is.
Of course.
Mr. Carney, Mr. Wang, any follow-up questions?
None for me.
Okay, what I'd like to do now is take a 10-minute break and come back on. We may determine that time we will, break until the public comment, but if it's 1:07, so let's come back on at 1:20.
Thank you.
Thank you.
And everyone mute your Zoom.
I can't get the audio. I get a view, I don't get audio.
Attorney Fusco, you ready?
Oh, we're muted.
You're good now.
Okay, yes, we are. Thank you.
Okay, I just have a couple of follow-up questions. Regarding the money on the transportation that we spoke about earlier with Ms. Hanley, and we talked about restricted funds or reserve funds. Where are those funds coming from?
So this was, so the Hatch Foundation divested itself. And so the Hatch building, which is part of Windham Hospital, was, became part of the hospital, and the funds remain in the Windham Hospital Foundation. And the restriction has always been, as I said earlier, for maternity, women's health, and rehab services.
Okay, so can we get a copy of that, those restrictions on the
Certainly,
funds?
absolutely.
Okay, great. Is that considered a charitable gift?
Yes, yes. And it's tightly restricted, and this is the perfect opportunity to use those funds in the way in which they were intended to be used.
Okay, all right. So if you can send us the restrictions, that would be good. Okay, is there any follow-up, Mr. Carney or Mr. Wang?
I'm also Attorney Yando.
I'm all set as well.
Okay, Attorney Fusco, do you have any follow-up on the questions that we had?
No, I don't think so at this point. Thank you.
Okay, so what we're going to do now is we're going to break. 2 o'clock starts the sign in, and we will be back here by 3 o'clock. We will be back here at 3 to take the public comment, and we'll just follow the agenda after public comment. We will, OHS will follow up with questions. Then we will have applicants' closing statement and closing remarks from OHS. All right, any other, so we're gonna go ahead and we are adjourned now until 2 o'clock.
Thank you.
All right,
Thank
thank you. And everyone go on mute, please.
That is beautiful. Thank you so much. We feel and we feel blessed to have you as part of the team too in so many ways. Come in. Whoops.
Is there anything I need to do?
No, we're all set.
Okay, so sorry about that.
Yeah, he was probably just not sure who he was, but don't believe he was part of this meeting.
Hi, everyone. This is Brian Carney from the Office of Health Strategy. Just giving a little update. Attorney Yandel was doing double duty with a different meeting. She'll be back. We'll be reconvening the hearing in a few minutes. Okay, thank you.
I'm just making sure everybody's,
Attorney Yandel, can you give us a minute? We've got some people that are uninvited showing
yeah,
up.
yeah, I just walked into my office and I just want to make sure everybody's on mute, and I apologize for starting a few minutes late. I will be back on in a few minutes. Attorney Fusco, are you there? Okay, we are still recording, and we are back from our break. For those of you just joining us, this is the Office of Health Strategy hearing, and the docket number is 32394, 20-32394-CON. I do want to make a correction in the beginning of the record. I believe I gave the wrong docket number in the very beginning of this hearing. So just to correct, this is docket number 20-32394. The applicant here is Windham Hospital, seeking to terminate the inpatient obstetrical services at Windham Hospital. We had the technical portion this morning. We are now moving into the public comment. We'll call the names of, I'm Joanne Yondo, the hearing officer in this matter, and we will call the names of who have signed up to speak in the order in which they are registered. If we miss anyone, please raise your hand using the hand function. Speaking time is limited to 3 minutes. Please do not be dismayed if we stop you at the conclusion of your time. We want to make sure that we give everyone the opportunity to speak, and we want to be fair. Additionally, we strongly encourage you to submit any further written comments to OHS by email or mail it in no later than a week from today. Public comments that have come in already are under Exhibit F on our CON portal on our website, and all comments are considered, those that are written and those that we will hear today. If we start hearing the same comments over and over again, depending on how many speakers we have today, I may ask you to please address other concerns of yours if we've already heard them a few times. I just want to make the best use of your time, and certainly have you bring to us what you think is important. Okay, our contact information is on our website and on the public information sheet, which you were provided at the beginning of this hearing. Thank you for taking the time to be here today and for your cooperation. And I just want to also, I think through the audio, we did hear some inappropriate music. I think that was someone coming in that was not part of this meeting. Unfortunately, these are some of the things we have to deal with remote hearings. We were able to take care of that. So I do, apologize for that. Okay, I will take the list, public officials first. Leslie Greer from OHS has been the one taking your names and putting you together, and she may have to assist me at some point. I know names came in at different times. We will start with the first public official I have on my list. It's Representative Susan Johnson. And again, if you could please keep your comments to 3 minutes for everyone. And would anyone speaking please put on your video and of course your audio. So Representative Johnson, are you here? I don't hear any audio. Is that my?
She's coming. She did not think she was going to be first.
Oh, okay.
We thought we were going in order that the names came in. I apologize.
Oh, okay. Oh, that's okay. I have Representative.
Can you?
She's there now.
I'm good. I'm here. Hi,
everyone.
Okay.
Thank you so much. Hi there. Thank you
Hi.
so much for giving me the opportunity to speak today. I really appreciate all the work that you're doing on this and that we do have this opportunity. I am State Representative Susan Johnson, SUSAN JOHNSON, and I represent the 49th House District, in which Windham Hospital is located. This has been an ongoing issue in terms of the types of services that Windham Hospital has been trying to limit here in this area. And I really want to start by saying in my testimony that's written, we had started working to try and stop Windham Hospital from limiting our services here back in 2015 when the intensive care unit was discontinued by Windham Hospital. And we tried to get an Office of Healthcare Access hearing, but according to the Office of Healthcare Access, the statutory language didn't allow for that. So we went back to the legislature in 2016, and we finally presented some statutory language changes. And that led us to creating a task force that was done with Lieutenant Governor Nancy Wyman. And for the following year, we heard from providers, doctors, administrators from all over the state as to what to do. And we finally, they came up with the idea of creating the Office of Healthcare Strategy. So I'm very thrilled that we have the opportunity to have a hearing so that when these proposals occur, that we will fully understand what the impact on the community will be, what the impact on the people will be, what the impact on the healthcare provider will be, and the impact on the state in terms of making sure that our healthcare access is evenly distributed all throughout the state. And that is one of the focuses and purposes of the Office of Healthcare Strategy. So I'm very thrilled to be here. I want to just hit on some of the things that I find to be really concerning. One is we are one of the most distressed municipalities in the entire state. This has been going on for more than 10 years, according to the Department of Economic Development. Also, just recently in the Willamette Chronicle, we saw that the superintendent of schools indicated that our data from the State Department of Education indicated that 77% of the students are high need students in the Windham Public Schools. And that is due to poverty, language barriers, and special needs education requirements. So we have a really difficult situation we're dealing with here because the access to resources here is very limited. This was recognized also by Congressman Courtney, who provided us with creating a Medicare hospital, the only Medicare hospital in the state of Connecticut, so that we would be able to receive more reimbursement from the Medicare beneficiaries. We have between approximately 40% of the people here in the Windham area, and Windham itself, are on either Medicare or Medicaid or both. So we do have a real difficulty here with patient mix. Then Harvard Health began with its downward spiral, creating the limitations with respect to the intensive care unit. And then now, projecting a few years later, we now have their proposal to limit access to the maternity ward and delivery services. We have real limitations in terms of highway access. We don't have highway access, any immediate way to get in and out of Windham, whether it's Route 32 or Route 6. If there's an accident on those highways, then what happens is people are going to be stuck there for hours. I just can't imagine being in labor and on the verge of delivery and finding myself in an accident on Route 32 or Route 6, trying to figure out what to do next and not being able to move the car or the vehicle. We also have a lot of helicopter services in and out of Windham Hospital. And of course, if the weather is bad, the helicopter cannot take anybody to and from that place. So we have, to the best of my knowledge, we have about two people anyway that I know of who have found themselves on the road having a baby in labor. If they went to Windham Hospital first, then they would be in violation of the Emergency Medical Treatment and Labor Act of 1986. And that EMTALA law would create a situation for us, I think, to take a very serious look at what's been going on at Windham Hospital with respect to the maternity and delivery of babies there. And so for those reasons, and also for the fact that under the Connecticut General Statutes, Section 19A-638, when there is an idea or a thought of trying to eliminate an essential service like maternity and delivery services, that we are in, then in that circumstance, they need to approach the Office of Healthcare Strategy first before they eliminate it. And in this circumstance, that was not done by Windham Hospital. And for all those reasons, I hope that and I thank you all so much for taking a look at this. These are all very, very serious things, and we have a lot of needs here in this community, and taking away things from us will not help us at all. So thank you very much for your good work.
Thank you, Representative Johnson. Representative Annie Hughes.
Hi there. Thank you. Thank you for hosting this, and I really appreciate the transparency that this process allows the public and us as policymakers to participate. I represent the 135th District of East and West and Reading, but also serve with co-chair Johnson on the Complex Care Committee, which has oversight over Medicare, Medicaid patients. And for those reasons, I listened to a lot of this morning's testimony, and I appreciate the sense of safety that some of the attorneys and representatives from the hospital talk about, especially in keeping qualified obstetrics on call, close by. I totally understand that because I experienced firsthand as a patient of Sharon Hospital what it's like to be in an underserved community and close by to a maternity obstetrics state-of-the-art center that is now also in danger of closing. And I'd just like to point out with these two underserved rural areas, they were never going to be denser with families. I mean, now actually we're seeing maybe in the northwest corner an increase of young families moving in that expect to have maternity and prenatal care from their local hospital that may not be there. But it was never going to be served by big highways, and same with Windham Hospital area. It doesn't have big highways. There's no way to get fast when you're in a difficult labor to Hartford or a regional maternity center. So I really want to question how we can think outside the box, not with just today's very specialty model, but how can we serve an underserved community in a fairly small geographic areas in both these corners. Maybe stand up, as Representative Johnson was talking about, a federally qualified health clinic, a federally supported Medicare center. Can we dual purpose the maternity facility for other vital health center opportunities for these underserved areas instead of requiring them to go to Hartford or another hospital? I really think that we should be thinking about regional health service and how we are providing. We have a small state. There's no reason that when we have world-renowned health systems, Yale, New Haven, Hartford Healthcare, New Vance, that we cannot provide service, maternity, life-giving service to, and prenatal service to our rural areas and our underserved areas. And as a nonprofit institution, Hartford Healthcare really has to think long and hard about how it is serving the public good in this instance, putting the burden on expectant mothers to do the traveling in what might be the most difficult time of their pregnancy. So thank you.
Thank you. Leslie, I believe that's the last of the public officials that I have. Is that correct?
Councilman Rodney Alexander would like to speak from Willimantic.
All right, Councilman Rodney Alexander.
Hi, good afternoon, everybody.
Good afternoon.
It's a pleasure to be here, and as newly elected councilman for Willimantic, this is my #1 concern about getting OBGYN services back here in Willimantic, because this is how you break a small city. How can we expect young families to move here, reside, and raise a family, and there's no OBGYNs here? So my questions are, #1, Why did you allow this to happen? And why wasn't there a community meeting?
So, Councilman, so what we have, this is a public comment. So you're getting 3 minutes to speak, and I will certainly, any questions you have, I will certainly consider after public comment. OHS staff will take
Okay.
the opportunity
All right.
to follow up with any
Okay.
questions. So you
Okay.
can certainly propose your questions and we will consider them.
Okay, thank you. Because to me, this seems like this was a systemic discrimination move to break a small city because of our Latino population that we have here and our low income people that we have here. I've been in this town for since 95. I've had grandkids delivered here. I don't understand this. I don't understand how you can expect anybody to travel down Suicide 6 or up Route 32 in labor to deliver a baby. Lord knows winter's en route. We all know how these roads get. They're poorly lit. There's no place to park, no cell phones. You know, this is just wrong on all levels. I really hope that Hartford Healthcare reconsiders this, because I'm just concerned, because what about any wrongful deaths that may occur? How are you going to handle that? You know, these are major concerns here. I don't know how often you travel up 32 or down Route 6, but Suicide 6 has the nickname for reason. I travel 32 every day to work. And one accident occurs, you have a backup forever. What happens then? You know, these were things that I don't know who made the decisions, but they need to be reconsidered. The critical care unit was pulled first, and now this. How can we expect our city to grow and the healthcare services that we vitally need for our public are being pulled? You say you're a community service. How was this a community service? Thank you.
Thank you, Councilman. Next on the list, I have Militia Cumberland, MD.
Hi there, thank you. Again, my name is Militia Cumberland. I represent Windham Hospital. I am Chief of Medicine, and thank you for allowing me this time. I've had the pleasure of serving at Windham Hospital for 10 years, and really for the past 80 years, Windham has been a great supporter of the community and providing exceptional care to the community and the members of this community. It's provided preventative care and urgent care, interventional care, as well as follow-up care. Windham has provided quality care to the members of the community of all shapes, sizes, genders, and ages, and the hospital has really remained committed to the changes that have occurred in Windham since 2012, which demonstrates that the administration for Windham Hospital really does care. But somewhere along the line, some of the members of the community lost trust and almost a sense of abandonment, as some of the members believed that we no longer cared. And I'm here to say that that's simply not true. We are vested in the well-being, the safety, and the longevity of the members of this community and its surrounding communities. The decision to close Windham Hospital's OB unit is directly related to the changes that have happened within our community. Less births were occurring in the hospital, less women were coming for their prenatal care. And due to this shift in 2020, we had less than 100 births occurring at Windham Hospital. With this low volume, obstetricians, gynecologists, and pediatricians were unable to adequately maintain their skill level to deliver the quality and safe care associated with prenatal, obstetrical, and medical and pediatric care. In addition, Windham was really unable to provide the necessary supporting services to support our OB-GYN colleagues, such as round-the-clock anesthesia coverage, a neonatologist, a neonatal unit, a blood bank, And lack of those resources combined with declining skills of providers, nurses, and their auxiliary care team, including the respiratory therapists, really provided subpar environment for safe quality care. Windham just cannot put our patients at risk like that. As a chief of medicine at Windham, I witnessed Windham's adjustment in the inpatient unit as well. Several of you brought up the critical care units. The members of the community who lost trust in the community in Windham was not just from the obstetric care unit, but also apparent loss of the critical care unit. And that is also not true. The renaming of the critical care unit was to transition to a progressive care unit in order to be more consistent with the level of care we historically provided and to more appropriately reflect the already patient population we had. Prior to the transition to progressive care unit, the critical care unit population declined. So our 12-bed CCU was converted to a 4-bed PCU and an 8-bed medical surge unit to better match the complexities of the patients we were already having. Windham still keeps the same level of care patients, and the patients that were previously transferred to tertiary facilities for higher level of care continue to be transferred. If anything, the transition to PCU heightened the level of awareness for providers and nursing, forcing them to recognize when a patient needed to be transferred faster to a tertiary care center. The quality and care, this is what we show. This is quality, this is safety. This is what Windham has always done, which is put the needs of the community first and its members. So whether it's the closure of the obstetrics units or transition from PCU to CCU, transitioning from CCU to PCU, these decisions were made in order for Windham Hospital to continue to do the safe thing. And as a leader at Windham Hospital, I'm tasked to continue and make sure that we do the safe thing. And more importantly, as a Black woman and a Black leader at Windham Hospital and a Black mother, my additional task is to do the right thing. So the right thing in this case is to advocate for the closure of the Windham OB unit. Our Black and brown mothers are higher risk of gestational diabetes, hypertension, preeclampsia, premature labor, and our Black and brown babies are at higher risk for prematurity, abnormal birth weights, complications from maternal complications, and stillbirth. So if we know that, why would we decide to keep high-risk babies in a potentially high-risk environment? We simply cannot put our patients, our mothers, and our children at risk. Thank you so much for allowing me to voice my opinion.
Thank you. Dr. Mary Berry.
Hello, and thank you for the opportunity to speak. I was a primary care physician for 34 years in Windham. I'm currently a per diem hospitalist. I work with Dr. Cumberland, and also I'm currently the chair of the East Region Board of Directors. I'm dedicated to Windham Hospital. I love Windham Hospital and have seen the delivery of all aspects of medical care, which is a universal phenomenon in the US, including obstetrics, significantly changed by necessity in the last several years for several reasons. Increased specialization and advances in training and technology, with many newly trained physicians choosing specialty rather than general medical practice. This has led to not only a severe shortage of general obstetrician and primary care physicians, but the aging physician population are choosing to limit their type of care provided to focus on what they're comfortable and capable of providing in their offices mainly. They cannot provide expert care in an ICU, for example, where specialists and hospitalists are providing 24/7 care. Smaller hospitals like Windham cannot and should not provide services that are not at a volume to maintain the expertise and technological advances required for current, potentially complex care. Windham has had enhancements in many of its services benefiting the community, including women's health. It is not a simple matter of more money infusion. Patients deserve the best care provided in the best environment. Having no neonatal resuscitation or 24-hour anesthesia is dangerous. In fact, if I was a mother who had had an uneventful pregnancy yet still had a delivery that required urgent care for my newborn and it wasn't provided, but could have been at another hospital with an adverse outcome for my baby, there is no excuse for that at all in 21st century medical care. The current generation of doctors require less on call and a more balanced lifestyle. Obstetricians now expect to work in a larger group with advanced 24-hour services provided. The obstetricians in this morning's testimony have explained this, and there's written testimony from the lead obstetrician of the group that left Windham, Dr. Rob Gildersleeve, providing this explanation as well. What Windham can and does do well here for women's health, they are committed to continuing prenatal and postnatal care, an individualized labor plan, transportation to the best level obstetrics care with all ancillary services available, and emergency delivery if needed. Quality and safety are the motivation for this proposed certificate of need request, and it's that simple. I'd add that our primary responsibility as a board is oversight of quality and safety to the community served, and we take that responsibility very seriously. We have been well informed by East Region President Donna Hanley about the issues leading to the changes in obstetric services. As a board, we support the certificate of need request for closure of OB services at Windham in favor of the current delivery of OB services plan to provide safe and high quality obstetric services to all mothers, babies, and their families in our community. So thank you for allowing me the opportunity.
Thank you. Joseph Zuzel?
Good afternoon. My name is Joe Zuzel, and I'm the manager of community health at Windham Hospital. I spend the majority of my career in the social services sector, advocating for individuals of all ages from various backgrounds in education and healthcare. I'd like to briefly explain our current hands-on grassroots community programs and the beneficial community impact that we've had. Healthy Beginnings is a program that President Donna Hanley had mentioned earlier. It serves new mothers and their babies who use the Windham Women's Health Center for pre and postnatal care. The program promotes healthy recovery for new moms and healthy growth for infants through access to community services. 2 home visits are offered beginning around 1 week after delivery to assess the needs of the new mom and baby and to coordinate and refer the mom and baby to community resources that are available. The home visits offer the new mom an opportunity to discuss any concerns or challenges they may be facing in taking care of their new infant. A licensed RN from Windham Hospital and a community health worker from the Health Education Center perform the visits, and an in-person translator is also provided if necessary. Services include wraparound care. So for example, information and assistance in applying for Husky insurance, SNAP, EBT benefits, fuel assistance, care for kids, diaper bank locations, plus information about our local lactation consultant and healthy growth and development for infants. This partnership also provides training, education, and work opportunities for individuals from diverse populations who are interested in the healthcare industry. Another program is the RX for Health program, which provides nutritionally at-risk families with prescriptions from their doctor or other healthcare provider for fresh produce. Funded by Windham Hospital, each family is given $126 in vouchers. Windham Hospital collaborates with Generations Family Health Center to identify families who would benefit. Families exchange the vouchers at Willimantic Food Co-op and the Willimantic Farmers Market, and Windham Hospital dietitians also provide nutritional support to families. We also have the Healthy Cooking Initiative, which identify individuals who would benefit from learning about meal preparation and menu planning to assist with their diabetes diagnosis. Windham Hospital's Food Services Director and Executive Chef teaches how to prepare meals at a local teaching kitchen in Windham. Participants cook, learn kitchen and meal preparation skills, and receive education about choosing foods suited for their diagnosis, plus ways to maximize meal planning on a limited budget. Our vaccine equity program provides education and equitable access to COVID-19 vaccines for our historically underserved and diverse populations. We work with community partners on educational events, mobile vaccine clinics, community outreach, and vaccine registration. Windham Hospital participates in, provides resources for, and sponsors local events within the Windham community. We continue to provide culturally relevant health education at events like Latino Fest, Unity in the Community Day, and Willimantic Downtown Festivals. We opened up a new farm stand at Windham Hospital this year to provide another access point for fresh fruits and vegetables to the Windham community. Windham Hospital is proud of what we do for the people we serve, and I'm honored to do this work on behalf of my employer and for our community. Thank you.
Thank you. Paul Pachenko?
Good afternoon, everyone. My name is Paul Pachenko. I'm the EMS program manager for the Windham Hospital. Since July 2020, we have transported 22 patients safely by ambulance to Backus Hospital without incident, 100% successful. 15 women were also transported from Windham Hospital by ambulance. 7 women were also transported from home or other locations to Backus Hospital. Emergency medical transport is also available to women 24/7 at Windham Hospital or from their home or other location by simply calling 911. In addition to these points, from 9 a.m. to 11 p.m., we have several commercial ambulances locally available to us with a 10 to 15-minute ETA to the hospital. These services are Ambulance Service of Manchester, Aetna Ambulance, American Ambulance. And if we need an ambulance within 5 minutes or less, we can utilize the Willimantic Fire Department, which carries an MICU license for their ambulance to transport a patient that needs to get out the door rapidly from the emergency department. From 11 p.m. to 9 a.m., we also utilize Hunter's Ambulance, an additional service, and that ambulance is dedicated to our facility and is parked in our parking lot during those hours. So an ambulance transport is also provided free of charge for women needing transport to Backus for delivery. And Windham Hospital is billed directly for these services. In addition to these things, we've also notified all the regional dispatch centers in the area, QV, TN, the Willimantic switchboard of our OB service currently. So they can remind any EMS crews that may attempt to bring an OB patient to Windham Hospital to seek another safer option if it's viable to them. When an obstetrics patient presents at the emergency department and they are identified as needing transfer during from 9 a.m. to 11, the emergency department will call what we have called the CLC, and they coordinate the transport based on the clinical urgency. And that's how we decide which service to utilize. The Windham Hospital Paramedic Service is also available if this transfer is deemed to be advanced life support. The Windham Hospital paramedic team is also certified in neonatal resuscitation, NRP, and that obviously is advantageous in this situation because NRP basically is resuscitating newborns that require it immediately after birth. That is an additional certification that our paramedics carry that most paramedic services do not. So when an obstetrics person presents at the emergency ward, they identify as needing, excuse me, if a woman cannot get herself to the department, she can easily call 911 from home and she'll be transported that way. I would say utilizing lights and sirens for a transport from Windham Hospital to Backus Hospital in Norwich. Utilizing lights and sirens, it's approximately 10 to 15 minutes. Under normal driving conditions without lights and sirens, it's approximately a 25-minute drive. I would say based on my experience, I believe the transportation plan that is in effect at Windham Hospital is safe and effective. Thank you for your time.
Thank you. Wilson Camello.
Hi, good afternoon. My name is Wilson Camello, and I'm the founder and principal owner of Camello Communication. Our company is an independent Hispanic-owned marketing agency that specializes in providing culturally relevant communication to Hispanic and multicultural audiences. We have extensive experience in marketing healthcare with specific expertise in the Hispanic market. On a personal note, I actually grew up in Willimantic, first-generation Hispanic. I graduated from high school actually with the current police chief. My roots are in this community. I have many friends and family that live there, and I understand the challenges of communicating with diverse populations. I say this because Windham Hospital has engaged my company on many occasions over the last 10 years to assist with providing Hispanic community with important information about their healthcare, including changes in services, service enhancements, new access points, and other vital health and health-related information, always in a culturally relevant manner. Earlier today, you heard from many hospital administration and physician experts about the factors that led to the decision to close the obstetric service. I'd like to briefly just tell you a little bit about our efforts in working with Windham Hospital through this process to make sure that we get timely and accurate information about this decision out to the Hispanic community, again, in a culturally relevant manner. Windham Hospital is acutely aware of this issue that's faced by these underserved and underrepresented individuals in the greater Windham community, and understands that providing relevant information is one step towards addressing these disparities. Based on my experience, Windham Hospital has made tremendous efforts to inform the Hispanic community about the changes to the obstetrics program, including where to access service, transportation options, and what to do in the event of an emergency. Specifically, my company has assisted in many different ways. For example, during last year's community forum in August, we provided translation services during that public forum. We've created a women's health services website in Spanish. We've done a lot of outreach in the area of COVID-19, whether that's clinics information, safety information, et cetera. A lot of outreach and messaging in Spanish through social media, digital platforms, online communications, as well as in person, such as the Willimantic Latino Festival that happened this summer. We've done a video series in Spanish available online, hosted by a Spanish-speaking nurse to discuss these changes to the obstetrics program and to address questions and concerns of women in the community. Our community engagement is monitored for each event and outreach activity. The number of views is tracked, and based on this activity, we know we're reaching the community. Windham Hospital has made every effort to inform Hispanic women and their families about these changes, and has done so in a way that respects each person's cultural beliefs and with the understanding of how diverse audiences understand and consume healthcare. I want to thank you for the opportunity to share this with you and my experiences with Windham Hospital in outreaching to the Hispanic community.
Thank you. Heather Evans. Heather Evans.
I'm coming.
Okay.
Thank you so much for the opportunity to speak at this very, very important hearing, and I appreciate the time and attention everyone is paying toward this topic. My name is Heather Evans, and I live in Mansfield, Connecticut. As a representative of the Town of Mansfield Human Rights Commission, I come to you with grave concerns regarding the closing of Windham Hospital's labor and delivery services. In a wealthy country such as the United States, high quality, safe maternal child care should be the norm, but we know that that isn't the case. The US ranks last for maternal mortality among high resource countries. And over the past decade, while most countries have seen a decline in maternal mortality rates, the United States has experienced a 50% increase. We know that childbearing women from historically underrepresented populations suffer disproportionately high rates of pregnancy-related mortality and morbidity. Non-Hispanic white women experience 13 pregnancy-related deaths per 100,000 births, compared to 42.8 deaths per 100,000 for Black women. That's 13 versus 42.8. Racial and ethnic disparities for mothers and newborns in terms of quality of care and availability of care have persisted over time. The decision to close Windham Hospital's labor and delivery services was short-sighted and has far-reaching implications. This decision has resulted in many of our most vulnerable women losing access to care within their community. They're required to travel at least 17 miles to receive care, and many of these women don't have stable transportation. Additionally, the delay in care as they travel to other hospitals may result in injury or illness to the pregnant woman or her baby. Hartford Healthcare has indicated that closing labor and delivery services at Windham Hospital was based on declining patient numbers. However, little was done to address the decline, and the community was not involved in seeking a solution. And the financial argument doesn't really hold up for me, because I speak to you now as a nurse with a doctorate and 20 years experience in maternal child health. Now, prior to moving to Connecticut, excuse me, I lived and worked in Vermont. I was a nurse and then in hospital leadership at a critical access facility. That 25-bed hospital serves a geographically remote and underserved population. The catchment population of possible patients was very limited due to the geographic location and low number of people living in that area. Despite this, people traveled long distances to receive their full range of OBGYN care at the facility. They often bypassed other facilities in order to deliver their children at this facility. This morning and this afternoon, we heard concern for maintaining adequate skill level of providers due to low numbers of patients. I appreciate that. I appreciate the comments from both Drs. Cumberland and Dr. Berry, and I agree. But the maternal child health outcomes at the critical access facility in Vermont were outstanding. We provided extremely safe, high-quality care with the most successful outcomes. Due to the facility's creativity, vision, and focus on high-quality care, they became the place to receive OBGYN care and were financially rewarded for this. The maternity patients at that critical access facility were in fact extremely profitable for the facility. In closing, we know that providing reproductive care within our own communities helps to strengthen that community. We call upon you to reopen and actually strengthen the services for childbearing families at Windham Hospital. This will help address the known disparity in health outcomes for childbearing families. There's no reason that Windham Hospital can't become the place to receive OBGYN services, attracting patients from all over the state, just like that critical access facility in Vermont did. I would be happy to answer questions or to offer professional assistance in developing a safe plan for opening a high-quality maternity center at Windham Hospital rather than closing the center and limiting access to services within our community. Thank you.
Thank you. Nelson Walker, the second. Hello, Mr. Walker.
Hello, colleagues, friends, neighbors. I'm Dr. Nelson Walker, a retired community family physician and was a member of Windham Hospital medical staff for 34 years until 2018. I am testifying in opposition to the decision of Hartford Healthcare to close the OB unit at Windham Hospital. Quality OB care with equity for all members of our community is the need. You have heard the Hartford Healthcare presentation. I understand their concerns, but years ago, corporate Hartford Healthcare made the decision to bring on this CON. When Hartford Healthcare took over Windham, they cut back and did not support services that were in place. Patients were transferred and directed to other healthcare facilities. This was especially felt by the medical staff of which I was a member. The ICU was closed. Services like general surgery, cardiology, orthopedic surgery were withering with a dwindling medical staff that was leaving because of lack of support and resistance to being employed by Hartford Healthcare. Fortunately, there was a change in the CEO, and his replacements did recognize value of a strong community hospital and took steps to strengthen and expand the medical staff and invest in the future. Those investments paid off, but sadly, the same did not happen in OB. There was and still is an excellent OB/GYN group in Mansfield. They were delivering babies at Windham, but were not able to offer vaginal deliveries after C-sections. They subsequently moved all of their deliveries to Manchester Hospital. Yes, doing VBACs at Windham would have required a major investment in staffing. Not investing cost Windham a good OB group, their deliveries, and their OB services to our local community hospital. The COVID pandemic has underscored the discrepancies and inequities in healthcare due to socioeconomic factors and lack of community resources. We must have quality local OB care for our diverse community with its significant number of disadvantaged people with transportation issues, especially when there are emergent urgent conditions like being in labor. If the Windham OB unit is closed, there is no chance of attracting new OB providers to the community. No labor delivery unit at Windham Hospital is poor quality. Not enough deliveries also leads to poor quality. Hartford Healthcare must invest to recruit and maintain quality OB providers and staff who will attract more families to have their babies at Windham. Keep the OB unit open. Hartford Healthcare needs to make Windham the destination hospital of choice for all expectant mothers and their families in the community and surrounding towns. Good outcomes with positive family experience is quality OB care. If corporate Hartford Healthcare had the will, they could and would find the way to make this happen at Windham Hospital. This spoken testimony will highlight some of my submitted testimony, and I really thank you for inviting me and listening to me. Have a good day.
You too. Thank you, Dr. Walker. Francis Padilla.
Hello.
Hi.
Good afternoon, everyone. Thank you. My name is Frances Padilla, and I'm president of Universal Healthcare Foundation of Connecticut. I appreciate the opportunity to speak this afternoon in opposition to the elimination of labor and delivery services at Windham Hospital, an affiliate of Hartford Healthcare. The foundation's mission to accelerate the movement for health justice recognizes that health is a human right, fundamentally related and core to social justice and equity. And what we've been talking about all day today is really a social justice and equity issue. We stand in solidarity with the women and families in the Windham area community by raising concern on the need for equity and access to healthcare for everybody. The closure of labor and delivery services at Windham Hospital is really a direct byproduct of consolidation. This is not a high profit margin service. And I appreciate all the good people that work in that hospital and that we have heard from today. But there are corporate decisions being made by Hartford Hospital that have been being made since Hartford Hospital acquired Windham, and other hospitals in Connecticut have acquired other hospitals that are driven by the profit margin. The reality is that it's very disconnected from the community. So we heard today, decisions driven by low volume, so-called low volume, decisions driven by doctors not wanting to be on call, wanting to be able to be home with their families, safety concerns, which of course are very, very critical. All of that, it's very concerning to me that there has been such disconnection from the community over these last 10 years, that the solutions, the decisions that needed to be made couldn't be developed with the community in a patient-centered and community-centered way. And that instead they came from top down and they were done really in the shadows. And the fact that the hospital did not go for its certificate of need when it should have before closing services, before stopping services, is, in our opinion, a real disservice to the community. So we demand that Hartford Healthcare restore labor and delivery services at Windham Hospital, and that they're held accountable to the requirement to follow the certificate of need process. We also think that there's a real need for state-led health systems planning. That everything we've heard today, we know that healthcare in rural areas is difficult to access. In the 10 years between 2004 and 2014, hospital-based obstetrics care in rural areas decreased by 11%. That has a negative impact on maternal and child health. That has a negative impact on high-risk pregnancies. There's 82%, we heard this morning, of the patients who are seen in the prenatal clinic are Medicaid patients. And we also know that OBGYNs do not want to accept Medicaid. Medicaid does not reimburse sufficiently for them, and those patients are not a priority. And so this is really about getting decisions made that are informed by the community and that are informed by the state from a larger macro level of where are the needs of our state residents and how should the institutions address those, not just decisions made in the boardroom by however well-intended people sit around the board table. I will just close by saying that Windham Hospital, as others have said, is critical to everybody in the greater Windham area. Hartford Healthcare did not go through its certificate of need process to eliminate that service and should restore them, and the Office of Health Strategy should act accordingly. Thank you for the opportunity to speak to you today.
Thank you. Leah Rawls.
Good morning, everyone, or good afternoon. Thank you for the opportunity to speak on this very critical issue. My name is Leah, L-E-A-H, Rawls, R-A-L-L-S, I am the current president of the Windham Willimantic branch of the NAACP. And in terms of this particular issue, this is deemed as a civil rights issue and a violation of those civil rights, which is our responsibility to speak on behalf of protecting civil rights for our community. Our community is one of many needs, particularly healthcare access. And if the access to those vital life-saving services are interrupted, our community will begin to experience loss of life at rates that are unacceptable. You know, I really appreciate all of the new services that Harvard Healthcare has implemented in our community. However, I agree with the last speaker that this particular service is of vital need to our community. Women have the right to bring life into this world in their own community, safe and sound. And if Harvard Healthcare, when they originally took over Windham Community Hospital, I'm going to put emphasis on the word community. Why did not they develop a plan to increase the OB services, increase the anesthesiologists, increase the NICU? And I mean, just, you know, it feels like there was a depletion of services to our community and not an increase of services to our community, because we could have avoided this. This could have been avoided if the funding was put into Windham. And I heard the gentleman speak about the Spanish-speaking community being made aware of this decision, and I beg to differ. I beg to differ, because we have hit the streets asking our community, did they know this was happening? And the answers have been no. So I'm not sure who his literature is reaching, but I can tell you it's not reaching the average woman of childbearing age who is unaware that this is a critical issue in them potentially bringing life into this world. So, and you know, as a woman, as a Black woman, as a Black mother, as a representative of the Black community, I am appalled that we are dealing with this in the times of people facing hard economic issues. There's lack of transportation in our community. We can't even get a bus to Norwich, never mind an ambulance. You know, I have a story of a young woman who, in a psychiatric episode, was about to deliver, lived 2 blocks from our hospital. And when the ambulance was called, they head down Route 32 and her baby was born in the back of the ambulance. Tell me how that is okay. Tell me how that is okay, people. We have a hospital there. Put the money in our hospital and resustain our services. I'm really hopeful that we can build on Windham Hospital. We have a new orthopedics unit. We have a new, you know, nutrition and whatever units, but we don't have a labor and delivery unit.
Ms. Rawls, do you have any closing statement? I don't want to cut you short.
That's my closing statement.
Okay.
Thank you so much. I appreciate the opportunity.
Thank you.
You're muted.
I'm sorry. Ilda Ray? Oh, there we go. I'm sorry.
Hello.
Hello.
I'm Ilda Ray. Thank you. I saw your mouth moving, but I didn't hear anything. So my name is Ilda Ray. I gave birth to our baby girl, beautiful baby girl. She's behind me here. just graduated from Windham High School last year, and she's in her second year of college this year. We were treated with the best of care at the Windham Hospital, labor and delivery. I felt like I was in a hotel getting concierge service. I did want my own doctor at that time to deliver my baby, not a stranger from another town. I don't think you can base the closing of the labor and delivery based on the pandemic. We're back to what should be considered a somewhat of a normal situation, especially with labor and delivery. Rideshare seems very impersonal. I wouldn't want an Uber driver taking me and my unborn home, taking me to the hospital, or taking my newborn home. Hartford Healthcare has expanded other services which seem very, very well thought and lucrative for Hartford Healthcare. Why don't you invest in our underserved community, which is predominantly Black and Hispanics? I've listened to others share, and I agree with Representative Susan Johnson regarding accidents. There's a lot of accidents on the road. And I believe another paramedic said that his ambulance only runs till 11 o'clock at night. Well, I gave birth to my daughter at 8 o'clock in the morning, but I had to be at the hospital at 2 a.m. So in that case, if it is today and I can't get an ambulance to, let's say, Norwich, I would not want my baby to be born in the back of an ambulance or in an Uber if I couldn't get a ride. And I heard someone else say that they did a study on the people who do have transportation in this town. And I don't know who they asked, but the majority of the underserved community that I know of do not have transportation. They don't even have transportation to come to their child's school for an event. How do they have transportation to get to Norwich or Manchester? You know, I've sat here and listened. I listened earlier about the process, and I wish I had caught more, but a lot of this is your standpoint, the standpoint of Hartford Healthcare and your representatives, and I respect all their opinions. But I, as a mother, as a brown woman in this underserved community, I would love to see our labor and delivery return to us. Make it work. Hartford Healthcare has a lot of doctors under them right now. I know because my doctor went there. And I guess it seemed like that was the best possible for him. So why can't we make this work for us? You make it work for doctors that you want to come to Hartford Healthcare. So Hartford Healthcare, please make this work for our community, for our Black and brown, and all the other women who are having babies. Thank you. I will end with that. I don't want to be cut off. Thank you.
Thank you. Brenda Bookbinder?
Good afternoon. Brenda, Brenda, Bookbinder, Buchbinder, LCSW. It's an honor and a privilege to be here today to speak on behalf of the community and our wish to reopen the unit. June 2020 was quarantine conditions in this rural community. No vaccine yet. News of spread sickness and death, shortage of food, supplies, perilous trips to work as an LCSW and back home again. I heard the heartless blow of Hartford Healthcare announcement of termination of Windham maternity unit due to dropping numbers of births and no longer being safe. The second blow after the pandemic assault was an assault to my heart, my body, and my maternal history. How cruel and wrong this edict of loss to further marginalize the struggling rural community. Terminate and deny our sanctuary for new life and families when deaths are rising. I shared my tears and grief with this community, masked, online, spaced, and found shock, sorrow, and outrage growing. The coalition of community was born a year ago and are here today to deny the right of the termination of our maternity unit. I wanted to review my 3 births a little bit and how they would be different if I delivered now. My 3 deliveries were my 30s as a daughter of a mother who had postpartum depression. I feared that affliction might happen for me as well. I shored myself up with local trusted OBGYN, Janice Lee. Healthy nutrition, Lamaze classes offered here for my husband and me, and prayed for live and healthy babies. The first birth, a 9-month beginning, started with a faulty placenta, was shutting down. I had an amniocentesis and a quickly scheduled induced birth that went for 9 hours. It was very patiently attended to, and they explained to me that if I used anesthesia, his breathing and his heart would go down. So I had no anesthesia. There was no rush to do a C-section at a regional hospital, and my healthy son and dinner for my husband and me as new parents. Today, he's a firefighter at EMT saving lives. Birth 2, labored through the night, woke up with the urge to push to deliver, was able to take that toddler across the street and just made it to Windham Hospital. The second push, he was born. Resting calm, there was no non-physician delivery in the emergency room, and racing ambulance down terrible Route 32 into the arms of strangers. Family and support nearby is not like the Hartford Healthcare plan. Sibling visit for the bonding was right there at Windham. My 3rd birth, short but a difficult labor. The second one, by the way, is a Google engineer in California, and he's working on housing rights. Birth 3, short but difficult labor. Daughter born with breathing problems, no birth cry. Circle of OBGYN nurse and husband in the room with me, working to revive her for what seemed like an eternity, and then she cried her first cry. Relief of tears and rest and comfort of being close to home and family. No lifestyle ride like the Hartford Healthcare plan. Sibling visits in memory of my youngest child, safe and cared for in the loving sanctuary of Windham Maternity. I did not suffer postpartum depression, but who knows if I had been outsourced and regionalized away. My heart aches for mothers to be in the Windham area, marginalized by this Hartford Healthcare termination, whisked away and made a commodity, disregarded all during a pandemic. I weep for them that they will be far from family, familiar, and home, and thrown into risk and stressors unnecessary and wrong. They have been suffering for the past 1.5 years. Hearing officers and community listen to the stories and bring us justice today, safety, compassion, and health equity into your hearts and minds as you make your decision. Let families start here, grow here, and be cared for here. I beg you do the best and righteous thing today and end the termination. Reopen and enhance our beloved Windham Maternity Unit. Thank you.
Thank you. John Brady.
Good afternoon. Thank you for this opportunity. My name is John Brady, John-B-R-A-D-Y. I'm a registered nurse who worked for 21 years in the Bacchus Emergency Room. I am now the Executive Vice President of AFT Connecticut, a union of 30,000 members, including the staff at Windham Hospital, the staff at Windham Public Schools, and at Windham Technical High School. We also have members at Natrog Hospital, EastCon Regional Schools, the University of Connecticut, and various state agencies in the Windham area. So as you can see, our members are part of this community, and the loss of labor and delivery would adversely affect them and their families. Our members, as healthcare and educational professionals and as public servants, also feel an ethical responsibility to advocate for quality, accessible healthcare. We believe that Hartford Healthcare has manufactured this decrease in births, similar to what happened in 2015 with the decrease of number of patients in the intensive care unit. We feel this was done in a deliberate attempt to close labor and delivery because they see it as a redundant service now that they control both Windham and Bacchus hospitals. While not every hospital must have every service, we feel these decisions are best left to up to the needs of the people of Connecticut. not the financial gains of an already profitable hospital corporation. The people of Connecticut and the Connecticut General Assembly agree with us, and that is why we have a certificate of need process in Connecticut. Hartford Hospital has violated the spirit, if not the letter, of the certificate of need process by discontinuing labor and delivery and then asking for permission to do so. We also believe that Hartford Healthcare has the financial resources and ability to safely staff labor and delivery at Windham, as evidenced of their investment fund of $4.1 billion. We urge the Office of Health Strategy to listen to the community members who have spoken out and signed petitions, to the many groups you will hear from today, to the city councils of several towns, to the area state legislators, and the Attorney General of Connecticut, who have all expressed concerns about this decision by Hartford Healthcare. We urge you to reject the certificate of need application. Thank you for the time. Thank you to the Office of Health Strategy for all you do to protect the people and the patients of Connecticut.
Thank you. I would just like to tell everyone or ask everyone to please refrain from using the chat other than for public sign up. Next on the list, well, I believe Representative Susan Johnson already spoke. Arvind Shaw. Hello, Mr. Shaw, go ahead.
Good afternoon. Good afternoon. Thank you for conducting this hearing. My name is Arvind Shaw, A-R-V-I-N-D-S-H-A-W. I'm the CEO for Generations Family Health Center. We serve 18,000 patients in the service area of Norwich, Danielson, Putnam, and Willimantic, where I'm speaking from. On behalf of the communities we serve, I'm speaking because I'm not speaking for myself necessarily or for our health center, but I'm speaking for access for all women in every community. I'm asking for a full and fair hearing on this matter as possible, to give voice to those who often go unheard in legal and regulatory matters. I want to go back to June 2015, when Hartford Healthcare proposed and was granted removal of the ICU. And they published a document called the East Region Transition Plan. I have made a copy of this available to you. But it talked about the changes that were inevitable for this community. And it also was produced in connection with the OCA termination of the ICU. But the hospital assured us at that time that they were committed to offering cornerstone services, which specifically included women's health services. Today marks 22 months since the hospital has interrupted and discontinued maternity services in a community which has relied upon these services for decades. They've done this without community input. They've abandoned a cornerstone service with no proper notice to the community or regulatory approval or oversight. And it's truly a tragedy for the services, for the families who depend on these services. I'm asking that you deny these based upon the OHS's criteria itself. It's not consistent with the OHS policy and the relationship of the statewide healthcare plan. The latest statewide healthcare plan, OHS says, and not-for-profits have an opportunity to redress inequities and disparities by listening to communities, and that community health assessments, CHNAs, are a sound source for the identification of these healthcare needs and disparities that are present in the community. Windham Hospital identifies numerous racial and ethnic and economic challenges and comparatively high Black maternal mortality rates, and transportation as significant issues. This CON is completely inconsistent with all of that above. There's a clear need that a public health need is not being addressed. Windham County is ranked last in the state and has been ranked last in the state for at least 20 years.
Mr. Chair, I don't want to cut you off, so if you could just wrap it up, because you're over your time, but I will certainly give you a little bit longer to wrap it up.
Thank you for that, Grace. I appreciate it. Numerous studies have shown that, look, that these have a cascading effect on community health. I would suggest that at very least, the hospital restore these services. The hospital's legacy of investing and supporting quality care, quality maternity services be resumed, and OHS provide us with guidance, because there are stakeholders involved over here who could come up with very innovative and creative permanent solutions to address this public health care need. But what is really needed is regulation and some kind of a benchmark or some kind of a blueprint for us to follow. Thank you so much.
Okay, thank you. Chair Kapelner-Champ. Hello.
Okay, Chair, C-H-E-R, Kapelner, K-A-P-E-L-N-E-R, Champ, C-H-A-M-P. Good afternoon to all who have gathered today for this urgent situation. As a retired nurse, mother, and grandmother, my offering is the following as I read today, AKA Mother Lightning. This poem is dedicated to the women and children of the world and is inspired by true events as told authentically to me, its author. So rocks the cradle. Hung over with love and great concern, so begins the day. Misplaced, such is life. Matrushka, you sit on my shelf, flowered and graced, lacquered so thin as your head goes pop. On the side of the road, the poor woman screams in her labored birth, Mid-Eastern borders, Willimantic too. Always, yes, always, tomorrow, they say. But the birthing room's gone, no doctors in sight, as the world's women wail, bleeding, erupting, forever in a day. Thank you.
Thank you. And I skipped one out of order. Nan Kyer.
Hello, my name is Nan Kyer. I'm a registered nurse and lactation consultant. Last name Kyer, K-Y-E-R. I'm not going to stand here and tell you about the high and rising maternal mortality rate in the United States and how Hartford Healthcare's plan to permanently close the maternity unit will contribute to that rate, because you know about that already. I'm not going to stand here and tell you about health disparities, their impact on patients and their families, and how these impacts reverberate out into the community for generations, because you know about that. I'm not going to tell you about the especially vulnerable populations in the greater Windham community, their need for accessible, high-quality healthcare at delivery, because you know about that. I am going to appeal to your sense of justice and a presumed hope for something better. The potential closure, permanent closure of the maternity unit at Windham Hospital provides the opportunity to re-examine who we are as a community and reaffirm the value of all people. This event opens discussions related to access to quality health services and the profit motive within the healthcare system. It's time to walk our talk. If collectively, we, the greater Windham community, Hartford Healthcare, and public health agencies state that we want to address healthcare disparities, that we want women to be equal and valued members of our society, that we want high quality healthcare that is accessible to all, the Windham Hospital maternity unit should be reopened. Requiring women to labor and deliver in the emergency department, in an ambulance, or at an out-of-town hospital separated from their support system disregards these objectives. It is said that a society can be judged by how it treats its most vulnerable persons. Perhaps a healthcare system and a public health governing body can be judged by the same criteria. My hope is at the end of the day, we do the right thing and reestablish this community's maternity unit to enable safe, respectful, and compassionate care for delivering women and their families. Thank you.
Thank you. Jonathan Gonzalez Cruz.
Good afternoon, Office of Health Strategy members. My name is Jonathan Gonzalez Cruz. I am a recent graduate of UConn's Masters of Quantitative Economics program and work as a healthcare organizer for Connecticut Citizens Action Group. I also became a new parent in October when my newborn was born. Today, I want to testify in opposition to the closure of the maternity ward from both a personal experience and economic arguments. As I mentioned, last month I welcomed my newborn, but before doing so, my partner and I, as expecting parents, felt fortunate to live in a town where in all directions there was a hospital accessible should anything happen. On October 11th, as both of us were getting up and ready for work, we were unexpectedly rushing to the hospital because our newborn was on their way an entire month early. With many thoughts flooding our heads, such as, will they be okay as a preemie? Will my partner be okay? I felt reassured that we got to the hospital in a timely manner and were assisted. Unfortunately, for all the expecting parents in the Windham area, they do not share this reassuredness from Hartford Healthcare. Hartford Healthcare has indirectly informed them that they, as patients, are less of a priority in their closure of the Windham maternity ward. A recent community health needs assessment has highlighted how transportation is a key barrier for folks in that area. Given the poverty and uninsured rates in that area as well, this further exacerbates the inequity those expecting parents are experiencing if they do not have transportation to the hospital and with a lack of health coverage would not want to or can't even be able to pay thousands of dollars just on an ambulance ride alone. In the case of health needs, especially in labor and delivery, timely access to professionals who are able to take care of the patient and the newborn is imperative. As Irvin Shaw, CEO of Generations Family Health, mentioned in his written testimony, numerous studies have correlated the removal of maternity services from the community with the decline in prevention and early detection services. Given how Windham County is ranked last in the state in most health outcomes and leads the state in health disparities for the last 2 decades based on My County Health ratings, there is a clear data-informed answer to should the maternity ward remain closed, and that is a resounding no. Hartford Healthcare should immediately restore maternity services for the people in the area. Every day, every week, every month that this is not done puts the lives of patients and their newborns in danger. I hope for the safety and care of the Windham area people that the Office of Health Strategy listens to the community, listens to the opposition to the closure, and informs Hartford Healthcare they must reopen the maternity ward. Thank you.
Thank you. Rose Reyes.
Rose Reyes, R-O-S-E-R-E-Y-E-S. Good. I appreciate the opportunity to comment on the proposed closure of labor and delivery services at Windham Hospital. I'm Rose Reyes, resident of Willimantic, 20-year bilingual educator, vice president of Windham Federation of Teachers Local 1577 AFT, and serving my second term as a Working Families Party council member on Windham's Town Council and completing my tenure on the Planning and Zoning Commission. I support the Windham United to Save Our Healthcare Coalition and its position on why this request for permanent closure of the labor and delivery services is unreasonable. When we take note, as you've heard in many testimonies before, the relationship that HHC has to Windham, you can't help but notice a pattern and tendency to take advantage of our vulnerable community. And we're all aware of those actions, such as the changing the intensive care to progressive care from 12 beds to 4 beds, eliminating 418 jobs between Windham and Bacchus Hospital, closing the Windham labor and delivery services without proper authorization or adequate community discussion in the midst of the pandemic, justifying a service closure due to a low count when the service closure exacerbates a low count. And all the while, HHC is making billions in their hedge fund investments during this very same pandemic. All of this is rather conflicting of an entity in the healthcare field, allegedly here to help a most distressed community. Remember that the Department of Economic and Community Development has ranked us as the most distressed municipality in state, and that our families are among the most underserved. HHC's behavior seems greedy, it seems audacious, and is based on a false narrative and a pretense of true service, and fundamentally, ill will towards our working families. We stand against the certification of need because it is a false need, it is unfair, and it is paralyzing a community attempting to reclaim itself in the midst of this pandemic. Thank you for your time.
Thank you. Lisa Thomas.
Lisa chose not to testify. I
Okay.
believe she's including something in writing.
Okay, and that's fine. Rodney, we had Councilman Alexander already spoke. Mary Calucci.
Mary Gallucci, MaryGallucci. Good afternoon. I gave birth at Windham Community Hospital 23 years ago. The care was first class, unlike what I heard described this morning. A supportive environment is fundamental to a healthy birth. I spent much of labor at home. Even without complications, labor does not occur on schedule, nor for a set time, which is why comprehensive medical services within reasonable reach are necessary. Living close meant no anxiety about travel. Because I was calm and comfortable, I required no medication or interventions. Prenatal classes were key to my healthy birth and breastfeeding experiences. Such pre, peri, and postnatal medical care pays off in optimal outcomes for women, babies, families, and communities. My individual experience is a testament to the fine tradition of caregiving at a community hospital, but it must be placed in a larger context. The last thing a pregnant woman should worry about is getting to a hospital. Research in Holland, where healthcare is universally available, finds that travel time of 20 minutes or more by car is associated with an increased risk of mortality and adverse outcomes for women at term. Distance is not straightforward. How far is too far cannot be measured in terms of city blocks, miles, or even minutes. A distant ride may preclude the presence of family members. The ability of a family to share in the joyful event of birth is curtailed when women must travel to hospital. Stress and anxiety during labor can trigger emergencies, resulting in invasive medical interventions such as cesarean sections. The United States has one of the world's highest cesarean rates. Public health efforts are focused on reducing this. Incidence among first-time mothers with no complications is high, over 28%. The chances of future surgical birth are strong. Scientists have shown that where birth takes place matters. Connecticut is in the top 10 of states for high cesarean rates. Research reveals that hospital practice and medical decisions contribute to the high rate of C-sections among all mothers. Health insurance and ability to pay are factors doctors and hospital corporations use to determine what kind of pregnancy and birth experience women have. This practice is discriminatory in outcome, if not in intent. Poor women struggle to obtain preventive care. In the United States, a significant racial and ethnic disparity in maternal mortality exists, with Black women being 3 to 4 times more likely to die from pregnancy-related causes. The local OBGYN practice stopped taking Medicaid patients. Medicaid covers over 40% of US births. The Medicaid program is arguably the most important maternal and child health program in Connecticut, said Mary Alice Lee of the Connecticut Voices for Children. Medical care might be coordinated in a regional manner, but women in labor should not be the ones traveling. Based on my experience, pregnant women deserve to receive risk-appropriate care in a facility equipped with the proper resources and healthcare providers in their local community. We should investigate whether providers are reluctant to come to Windham Hospital or if it's Hartford Healthcare that they're reluctant to work for. Thank you.
Thank you. We already heard from Representative Ann Hughes. Bill Powers.
Good afternoon.
Afternoon.
My name is Bill Powers, B-I-L-L, P as in Peter, O-W-E-R-S. I want to let you know that I'm an honest-to-God consumer, okay? I Unlike a lot of folks that spoke earlier today from Windham Hospital, they're probably paid by Windham Hospital. So I'm an honest to God consumer. I live in Windham Center. The closing of the maternity unit at the Windham Community Memorial Hospital creates a critical barrier for members of our community. The lack of local access for our community certainly impacts our many immigrants and refugees. For them and many others, the lack of reliable transportation to other towns and cities is just one of the difficult problems that they are forced to contend with. I guess for the leadership of Hartford Healthcare, where you live says everything. Our women and babies deserve the kind of services offered to others elsewhere in the region. That is top-notch, full-service maternity unit. The denial of this access amounts to a gross injustice in my estimation. When Hartford Healthcare announced the permanent closing of the unit, they said women were choosing to go elsewhere. On the contrary, by their own actions, Hartford Healthcare chose that women would be required to go elsewhere. That was not of their making. Talk about blaming the victims. After Hartford Healthcare came to town, the ICU was closed. 90 nurses were let go and inpatient beds were reduced. OBGYNs, that is professionals, were left due to the risk of working without an ICU and a support staff for the ICU. The maternity unit was doomed. Now, I would also want to say to you that I have in the past been a hospital administrator. I worked at Hartford Hospital. I worked at Mount Sinai Hospital in Hartford, and I worked at Bay State Medical Center. I was also a practicing respiratory therapist specializing in special care, critical care, and also worked at the ER at Windham Hospital as a mental health provider with a master's in clinical psychology. I believe that the women, the people of Windham and nearby communities require this basic service to meet their essential needs, healthcare needs, and those needs that they require. And that would be it for today. And I thank you and God bless you and stay safe.
Okay, thank you. You too. Jamie Rosenblatt.
Hi. Good afternoon, Office of Health Strategy members. My name is Jamie Rosenblatt. I'm an organizer at Connecticut Citizen Action Group. On behalf of our hundreds of member families in the Windham Hospital service area, I urge you to oppose the termination of inpatient obstetric services at Windham Hospital. The current pandemic that we are all attempting to navigate has been a stark reminder that we need to make sure everyone has access to healthcare for any of us to be truly safe, and reiterates the importance that healthcare spending must help strengthen our public health infrastructure. Instead of caring for their patients in an unprecedented and historical moment in time, Hartford Healthcare closed their doors to the maternity unit in Windham Hospital in the summer of 2020 without going through the proper process. Hartford Healthcare's acquisition of Windham Hospital was proposed to be the solution. They would keep medical services local for the community it serves and maintain quality services. Yet here we are, hearing a massive and extremely profitable entity cry poor. Maybe they're onto something. The time is now to end the commodification of healthcare. Patient access and care should be prioritized over Hartford Healthcare's profits. Windham Hospital serves an area that is considered to be medically underserved, and the population has a high comorbidity rate. Forcing pregnant women and their families to go elsewhere is not only illogical, it is also inequitable. This brings up the issues of transportation, for everyone does not have their own means of transportation, the family's ability to get to and support the expectant mother, and language barriers if the mother is transported but does not have anyone who speaks the same language. In instances when the expecting mother is transported via helicopter or ambulance, this is dangerous and costly. The windy back road from Windham Hospital to Bacchus Hospital is not a safe route for an emergency vehicle to drive on, and helicopter rides can easily be unreliable depending on the weather. So many things can go wrong during the birthing process. Why add another? Hartford Healthcare's PR talks about commitment to excellence and serving the region. These values are directly contradicted by forcing women to travel for maternity services. In addition, the closing of the Windham maternity unit will send the message to young people like myself that it is not an area where they want to settle down and have a family. No one will knowingly choose to live somewhere where they can't get the kind of healthcare they will need if they can help it. The war on women and the consistent disregard of rural communities and their needs must end now. You, the Office of Health Strategy, have the opportunity to protect basic care for thousands of women and families. Healthcare is a human right, and the pandemic has already exposed and widened disparities in healthcare by race, income, and geography. Closing Windham's maternity unit would be an enormous step in the wrong direction and continue to worsen these inequities. Thank you.
Thank you. Representative Brian Smith.
He submitted written testimony. I apologize. His name should have been taken off the list.
Okay, all right, thank you. Lynn Ide.
Good afternoon. My name is Lynn Ide, spelled L-Y-N-N-E, last name I-D-E. I am here today as part of Windham United to Save Our Healthcare and the Director of Program and Policy for the Universal Healthcare Foundation of Connecticut. I delivered 3 beautiful babies at Windham Hospital, and I'm heartbroken to say that the week before last, one of my children was unable to deliver my first grandchild at Windham Hospital because of decisions made by Hartford Healthcare. You've heard a lot here today from my friends and allies about why we should not do this, why you at Office of Health Strategy could step in and make a big difference in the lives of people in a medically underserved part of the state with a thing that connects many people to their hospital. If you go back and you ask people what they think about their community hospital, they tell you stories. They say, that hospital saved my father's life. That hospital is where my grandchildren were born. That hospital is where I went to deliver my babies. Those are the stories that people tell about hospitals. This story could end differently than Hartford Healthcare wants it to end. And you asked great questions this morning, the staff of Office of Health Strategy, and I hope you continue to dig to get to the bottom of some of the false and misleading answers that were given to you by Hartford Healthcare. They have shown an amazing lack of creativity and fortitude in solving this problem. There are examples of how rural hospitals around the country have worked to create solutions to be able to deliver safe, effective labor and delivery services at hospitals. And I urge you to ask Hartford Healthcare, order Hartford Healthcare to go back to the drawing board and figure this out. And the community stands ready to be a part of that conversation, which we've been left out of by Hartford Healthcare, despite anything that they may be saying in these public forums. We want to be part of the solution. We believe a solution can be arrived at. We don't believe it's impossible. We believe the situation that we're in right now with Hartford Healthcare and Windham Hospital was created by Hartford Healthcare. They created the story that got us here. We need to create a different ending to that story and return labor and delivery services to where they belong, here at Windham Hospital. Thank you.
Thank you. Susan Eastwood.
Good evening. Thank you for the opportunity to speak today. My name is Susan Eastwood, and I am speaking on behalf of the Permanent Commission on the Status of Women of Connecticut. I'm a board member and I'm also a resident of Ashford in Windham County. I'm deeply concerned about the inequities of the healthcare that have been exposed by the termination of obstetric services at Windham Hospital. Most of the women who are now and will be affected by the lack of obstetric care in the area are low-income minority women who will be more disadvantaged than most by the long distances they will have to travel for services, including childbirth. In 2020 to 2021, PCSW Connecticut conducted a study of the economic impacts of COVID-19 on Connecticut's women. In Windham County, 68% reported a negative impact on their health, above the statewide average of 59%. Women of Windham County also reported a higher than average rate of negative impacts on their health care, 45.5% versus the state average of 35.4%. This data illustrates that cutting medical services of any kind in this area of the state is likely to bring greater hardship in most areas. Obstetrical services are one of the most basic needs of women and families in any community, and a safe, accessible place to deliver your baby is a basic necessity for any family. This is especially true for high-risk pregnancies when the hospital care is essential. A loss of these services would be a major failure for any community, but it's especially concerning when the area is ranked as the #1 distressed municipality in the state. Windham has recently moved to the top of that list, I'm sorry to say. Many families in Windham do not own a car, and long-distance transportation to Hartford Hospital or Bacchus Hospital in Norwich is difficult and expensive to arrange and make family visits almost impossible. This is a clear hardship that exacerbates the disparities of healthcare in northeastern Connecticut. The distance to travel for healthcare has impacts on health outcomes as well. This compounds existing socioeconomic factors that impact public health and poor health status among low-income persons who already have less access to healthcare. The National Advisory Committee on Rural Health and Human Services has stated that the impact and loss of accessible obstetric services and increased distance to travel to care has been associated with increased risk of non-indicated induced cesarean section, postpartum hemorrhage, prolonged hospital stay, and postpartum depression. Another study found that in rural areas, the absence of active labor and delivery units is associated with a significant increase in perinatal mortality. If this becomes permanent, the women of Windham and northeastern Connecticut, a predominantly low-income minority population, will be deeply affected by the termination of maternity services that have been available in Windham since the 1930s. The PCSW of Connecticut opposes the removal of these essential cornerstone services from the people of Windham and the surrounding area and asks that these services be restored. Thank you.
Thank you. Amy Romano. Amy Romano. Is she with the Windham United to Save Our Healthcare group?
She had requested to submit her name through us, but she was not logged in from here.
Okay, again, I'll just try one more time. Amy Romano. All right.
I can contact her. She can submit.
Well, I'll move on. She can go to the chat if she comes in.
Okay.
Just let us know it. Elizabeth Hubner.
Hello, I'm Elizabeth Hubner. My name is spelled Elizabeth Huebner. I'm a Windham resident of Willimantic, and I want to talk about the difference between my two births. I gave birth in Minnesota to my oldest son in my community, and I had my family around me, and it was a very difficult birth. And the staff supported me enough so that I had a vaginal delivery. And in fact, the head of the birthing unit asked me how I did it because she's always trying to help people do that. That meant I could go home to my family 24 hours later. In contrast to my second birth, which was in Connecticut, I was a 39-year-old pregnant with twins, and I almost carried them to full term, but they were born at about 35 weeks. And so I had to go to Hartford. I have good health care. I have a husband who drives the car. We have, so we have resources. But my experience post-birth was very dramatically different. And a lot of that had to do with my experience of being not at home. So I had a cesarean section. So I had my first lifetime surgery, and I had twins that had to go into the neonatal intensive care unit. And 3 days after I gave birth, I was dismissed from the hospital. So I was 35 miles from home. I had a 4-year-old at home. My husband was working, and I had just had surgery, so I couldn't really walk very well, and I definitely couldn't drive. So my experience was that I was confronted with the situation of leaving my babies, which I was being encouraged to do, in the hospital and go home, which meant I couldn't drive, I couldn't nurse my babies, I couldn't be with them. It was very, very stressful. So no one's really talked about what happens after you give birth outside of your area. And if you don't have a straightforward pregnancy, then you are isolated from your support. What they did was, in Hartford Hospital, they kindly connected me with a social worker. I was given a free apartment with no phone, no anything. It was a bed and a pass to eat in the cafeteria. So I was just completely isolated so that I could spend time holding my immature babies, which are all fine now. But I think that is a piece that didn't get addressed by anyone else whose talk that I heard, that it's not just getting there, it's giving birth, and it's also then what happens after that if you're way away from home and your babies are way away from home. So I really hope that we can keep our maternity unit local in Windham for all of us. It's not just, people who have little resources, because that was not my case. Thank you very much.
Thank you. Thank you. Katina Caban-Owen.
Hi, good afternoon still to everybody. I'm Katina Caban-Owen, CATINACABAN-OWEN. I am a resident of Windham, and everybody in this town knows I'm a committed advocate to eliminate the social determinants of health disparity, and I'm a fellow of the Connecticut Health Foundation. For transparency, I'm a part of the Corporator Community Advisory to the Windham Hospital. I was for 9 years on the board of Windham Hospital, which at the time transferred the Windham Hospital to Hartford Healthcare. And for a while, I was also part of the East Region Board of Directors. The hospital has saved the life of my husband, of my sister, and has delivered the most precious nieces and nephews and godchildren that I have ever had. I am also a person who 40 years ago initiated with some other of the people who have testified here, bringing bilingual, bicultural translators and services. And in fact, years ago, I was a person who hosted Dr. Yvette Martas, who's part of the OBGYN, and who enthusiastically we recruit her to be here. I am in support that the labor and delivery maternity services are open again. I also know that because we don't have a local OBGYN and group, this has happened. So as a solution-focused person and as an advocate for all health services to be local, I say that Hartford Healthcare and we, the community, should get involved in hiring, recruiting, and the retention of OBGYN groups here at the local level for our young women and for all our services. Women prefer, as everybody has said before, come to our hospital. I want to come to Windham Hospital all the time for any needs. And everything that has stated is true about our community and our people of color. And pregnant women will come, like they say, if you build it, they will come again. But the main issue I see is to develop a plan jointly with Hartford Healthcare and our community to recruit, support, and maintain an OBGYN group that would serve our community. Thank you.
Thank you. Leslie, is there anyone else on the list? Okay, I just saw James Flores.
Hello, I'm James Flores. Can you hear me?
I can.
Okay, I'm concerned about how the hospital all around America, including Windham Hospital, becoming a money machine. The main goal is not to help people, is to profit from people.
Flores, I don't know, maybe you're calling in from a phone, but do you have audio, do you have video available?
No, I don't have video because I got an old computer. I can afford a computer. Okay. Or I'm a black Puerto Rican, you want to see my face.
No, that's okay. I can hear you. You're fine.
Okay. Everybody concerned about maternity room, but most of the hospitals are closed. I had a stroke 2 years ago. I have to go to New Britain because for the stroke, they don't have the services. Now, people for colonoscopy, they need to go other town because they don't have colonoscopy in Windham Hospital. I'm concerned about the CEO of the Windham Hospital get $1 million bonus. I'm concerned about the Wall Street market. The stock for Windham Healthcare go up to $45. Windham Hospital is about profit. Now Windham Hospital bought 100 acres land in Willimantic. They say in the beginning that they want to save money. How are you going to save money if you can invest the money in private land? Route 32 in Willimantic, they bought 100 acres land, and I don't know how much they pay, but if you buy 100 acres land, that's a lot of money. I want to encourage Hartford Healthcare to focus in human side, to help people and move away from profit. I'm concerned also right now, I can see the picture that on the Hartford Healthcare in the table. I don't have my glasses, but I see all white European. That's other issue. How many black doctors, how many people that work for Hartford Healthcare in the high rank are minority? My concern was that the reason to close Willimantic Hospital, because they're going to close on the road. The plan is to close everything. I'm racially motivated. Thank you.
Thank you. I appreciate your comments. I believe I've gone through the list. Leslie, is there anyone else?
No, that's all on my list.
Okay. Is there anyone here I haven't called? No, okay. All right. Well, thank you all for your public comment. I do want to make you aware that all your comments
Excuse me, Attorney Yando, May Flexer, I guess would like to speak. She just put her name in the chat.
Okay. May Flexer is, are you available?
Yes, I am. Can you hear me?
I can. You have 3 minutes. You can go ahead.
Can you hear me?
I can. I think you may go, I think you're going frozen. I think you're going in and out. Are you still there? Maybe if you take your video off, try taking your video off. That might. I'm sorry, Ms. Flexer? I can't hear you. Oh, there you go. Well, let's give it one more try. Try it again. I can see you.
Okay, can you hear me now?
I can.
Okay, thank you. I'm sorry for that delay, and thank you for calling on me. My name is May Flexer. I am the state senator for the 29th district, which includes the communities of Windham, Mansfield, Scotland, Canterbury, Brooklyn, Killingley, Putnam, and Thompson. And I want to thank you for your time.
You're going in and out again.
Attention to these ill day today and particularly hearing all of this public comment this afternoon. Those of my neighbors and my constituents who have expressed concerns about the closure of the maternity and obstetrics departments at Windham Hospital. You've heard in great detail this afternoon why this is so detrimental to this community. That by many measures, Windham is one of the most economically isolated and racially isolated communities in the state of Connecticut. And the deterioration of healthcare access in this community has been devastating. I do just want to emphasize a few points that have been made this morning and this afternoon in particular. I just want to say that this process really started when the critical care unit was eliminated at Windham Hospital. And in the time since that unit has been closed, Windham Hospital has made an effort to expand services in many health areas at Windham Hospital. But the decline of health services overall really started with that decision. And that decision led to a shakeup of our state statutes. And it's why this process is going forward here today. The ramifications of that closure of the critical care unit at Windham Hospital and other healthcare decisions made across the state is why my colleagues, led by people like Representative Susan Johnson and my Senate President, Senator Martin Looney, and others in the legislature, why we changed this process. And so to be here today, almost a year and a half after Hartford Healthcare made the decision to close and eliminate providing this type of healthcare, is a real disservice to the process that was set up. Why do we set up a process like this, a regulatory structure, a legal framework for healthcare decisions to be made in the state of Connecticut if an organization like Hartford Healthcare can move forward with closing services and not have to actually get the okay of this entity until a year and a half after the services have already been eliminated and the structures around those services have disappeared. I like to think that there is a way for this community to come together. I think you've heard today that there is a willingness by a variety of stakeholders to try to make sure that services can be delivered. Because this child last year, I could say from personal experience how terrifying it can be to have to rely on traveling in an ambulance when it's in close proximity to that joyful moment of welcoming a child into this world. And while it is a joyful moment, it is also a scary time. And the fact that women in this community cannot be assured that they can deliver their babies and start their families comfortably at their community hospital is really a shame. And so I'm thankful for this process. I want to thank everyone who's taken the time to testify today and talk about why this change is so critical for our community. And I hope that during your deliberations, you will carefully consider the downfall of the healthcare system that's happening here in Windham and make sure that the community is protected and that maternity care can be restored in our region. Thank you very much.
Thank you, Senator. Pam Wright. Pam Wright.
I couldn't find my unmute button.
Okay.
Yes, I am well past childbearing at this point, but my best memories of Windham Hospital were giving birth there for both of my children. And I will say that the scariest time for me was trying to decide when to go to the hospital. And I was so grateful that I didn't have long to go. I happen to be one of those lucky people who did not spend a tremendous amount of time in the hospital. And apparently my daughter also had the same experience. So deciding when to go is a huge problem. She, when she called me in the morning, she told me her water had broken, but she didn't have any contractions. So she didn't know if she should go in. She called her doctor, and her doctor said, well, if you don't have any contractions by 4, you better come in. Well, she called me at 4 and said, Mom, I've got a baby. She started going in, and she got to the hospital and delivered something like 45 minutes later. I have had several friends who have gone to Windham and were told you're not ready to be admitted, and went downstairs and waited and went back up a little while later and were admitted. For many women, to be sure, they may wish, and of course these are women who have cars or husbands to drive them, they may feel they have to go perhaps 40 hours, 24 hours when they first start having contractions and they're unsure. And that's a huge additional expense and amount of time that they're spending in the hospital, whereas if they were close, they could wait a little longer. They could go, if it were the middle of the night, they could wait a little longer. I feel like it's really, really a disservice to women, particularly those who have normal births, to have to wait. They're tempted then to schedule a cesarean, which they probably don't need and is not as good for them or their babies, just to avoid that long ride or that concern about, will I get there in time, or will I end up being pulled over at the side of the road telling my husband, help me deliver this baby. I think that's, if we were really concerned about the health of our children and the new mothers, we would not make them go far. If every bit of equipment is not available at Windham, they do have ambulances at that point that can take people to places where they would need to go. But to simply make the availability of being able to have a baby nearby because you can't have every bit of equipment for every possible emergency is not in the interest of any of our community members, I don't think. So that's basically all I have to say. Not to mention the expense, but just the stress, the additional stress on parents.
Thank you. Thank you. And again, we consider all the public comments, both the ones that we hear orally today and the ones that are filed. There are some already entered under Exhibit F in our CON portal. The record will remain open for written public comment for a week. So certainly if someone didn't have an opportunity to speak and wants to weigh in and give some public comment, I can certainly do that in the week to come. Again, and thank you all. Leslie, is that it?
Yes, Attorney Ando.
Okay, great, thank you. Okay, now we're moving on into the agenda. After the public comment, we have part 2 of the Office of Health Strategy questions. And these questions are basically a follow-up from what we've read in the public comment and what we heard today. And I would like to put it towards the witnesses for Hartford, for Windham Hospital, to ask for responses. So I'll start with Ms. Hanley. Excuse me? Oh,
we're here. We're here.
Ms. Hanley?
Yes, I'm here, thank you.
You've heard the guys. I'm going to ask each witness, and then I will give your also ask your attorney if she has any follow-up questions after you've spoken. But do you have a response to the public comments?
Thank you. I thought you had a question for me. I appreciate the opportunity. First, I appreciate and respect the public comments that we heard this afternoon. The passionate comments were very moving, and I just want to make that known. There are a few things I would like to clarify. One, no women have been transported by Lifestar. That is not part of the plan. Secondly, COVID disrupted our lives for the last 18 months. Wyndham Hospital filed the CON application on September 3rd. So less than 2 months after we made the decision to go on interrupted service. We had a formal process that we needed to follow. I personally contacted over 40 elected officials, community leaders, the mayor, the town manager of Mansfield. I have a long list, which I'd be happy to submit to you with the dates, including multiple conversations and meetings with Ivan Shaw. That took time. And we did that before we did hold the public hearing, which we held on August 10th. And then we had public notice in the newspaper. We had to follow the regulatory requirements for filing a CON application. So that was filed on September 3rd of 2020. And just as we've all been impacted by COVID, the Office of Health Strategy has also been impacted. So we're catching up. In the last year, 500,000, that's right, 500,000 healthcare workers have left the profession due to the unprecedented challenges of COVID, the COVID-19 pandemic. We have a national staffing crisis, which adds to the challenge. I want to be absolutely certain that OHS and the public, all of you, understand that the decision we made was absolutely driven by quality and safety concerns. I am responsible for the safety of every patient, every physician, every nurse, and every staff member. Given the conditions that we discussed during this hearing this morning, there was no other choice. This is not something we can fix. If there was a fix, we would have done it already. If there were physicians to be recruited, we would have recruited now. No practice will come. The Windham patients are at a higher risk, and that is exactly why they are better served in the system of care we have created with this plan. The plan that is in place to provide a coordinated, clear, patient-centered experience and optimal outcome has been proven to be appropriate, effective, and an exceptional approach to provide the best care to our community. The Hartford healthcare values: caring, which is we do the right thing; equity, we do the just thing; excellence, we do the best thing; integrity and safety, we do the safe thing, resonate so deeply with my personal values. These values are the foundation as I went through the decision-making process. So just in response, we cannot provide every service in every hospital, in every community in our state and in our nation. And I know that's been recognized. We do not have unlimited resources, especially when we think about the most required services of OBGYNs. And one final comment, the issue of the rising maternal fetal mortality. Many of you, multiple community members have addressed this, as other witnesses, the physicians who are here today. But now it's being reported in the lay press to educate the public on this national issue. And this was a confounding and a secondary data point for us as we made the decision to provide the best and safest care for the patients in our community. So I thank you for the opportunity to be here today, and thank you.
Okay, Dr. Borgida, I'm sorry.
Yeah, thank you.
Yeah, do you have comments?
Yeah, I just wanted to address a few things that were mentioned. I understand the Medicaid population in Connecticut quite well, and I don't know of any practice in central or eastern Connecticut that does not take Medicaid patients. So there's no abandonment, there's no lack of providers that take Medicaid. Every hospital in the region takes Medicaid, and all the private groups do as well. As was mentioned, at least 40 to 50% of all births in our area are covered by Medicaid. So it's not a lack of providers that want to care for these patients. And then a few other things that were mentioned about the complicated deliveries that didn't happen at Windham. That would not change whether Windham was doing obstetrics or not. We've been receiving high-risk patients from hospitals all over the region because the normal low-risk hospitals can't take care of these patients. For example, twins at 35 weeks that need a NICU, whether Windham was open or not, that's not a patient that would be delivering at Windham Hospital. We continue to get patients from all over the region traveling much further distance than going from Windham to Bacchus because they have high-risk conditions. Even for their prenatal care, they come to Hartford for the care that they require because of the complexity that they have. So regardless of the levels of care that are around, many patients still have to go to tertiary centers, regardless of the level of care in their communities.
Okay, Attorney Fusco, do you have any questions of any of your witnesses?
I don't know if you want to allow
I-
Dr. Cal, I just wanted to make one response, clarify a few points to the public comment. Is that okay?
Okay, yeah.
Okay.
This is Dr. Calla again. There was a fair amount of discussion about the rural aspect of Windham Hospital. And although it is not as urban, certainly as Hartford or New Haven, it is also not isolated in the same sense that the rural access hospital in Vermont that was discussed was. There are, as we've discussed, multiple other hospitals within a fairly short distance, within 20 or 25 miles of the hospital. It's not isolated in that regard. There was also some discussion about the inability for people to get transportation. Ambulance service is in fact available and readily available, as we described in our previous testimony and our plan of care, for patients who either present to Windham Hospital or who call from their homes to be transported to the appropriate location. So those things are available. The last thing I would like to mention is that there's a lot of discussion about healthcare equity. And to me, to take a population that is at risk based on its demographics and economics and have it deliver in a setting that we know is less safe for the same complications that they're at risk for would be inequitable, would be providing them with less care than they would otherwise get. And to be quite honest, healthcare equity is a huge issue in terms of trying to make this transition to be safer for this population. Thank you for the opportunity to comment.
Thank you. Attorney Fusco, any questions of your witnesses?
No questions unless Dr. Rodas has one comment to make, and then.
Yeah, if I could, Attorney Giondo, I just want to respond to a couple of the comments made, and I want to echo what my colleague said, but I'm just going to comment as an independent person who reviewed this. When I first reviewed the CON and I spoke to the folks involved, my question, like many of the folks who called in today and zoomed into the call, was the concern of, are we abandoning the community?
Okay, we're back on. I'm sorry.
And so my questions really pertain to a lot of the things that have come up today. What are the services we're providing to the women of the community? Not pregnant women only. I know we're talking about OB services here, but I want to just bring some perspective to it. Only about 4 to 5% of women are pregnant at any one time. That means the other 95% aren't. And when I heard about the commitments that Windham Hospital is making to the women of the community by breast services, by breast surgeons, general surgeons, orthopedic surgeons, primary care providers. And then when I heard today from Mr. Zosel, I had not heard before, about some of the services that it's providing to pregnant women in particular, not just the prenatal and postnatal visits, which are the multiple visits as opposed to the one-off have the baby visit, are all provided in the community. And besides that, then home visits after women deliver. I wish I had been doing that at the hospitals they serve, to be honest with you. I felt a little guilty listening to some of those services. That to me showed a significant commitment to the women of the community. So I think, having been the president of a Catholic hospital, we talked a lot about ethics and particularly the ethical principle of distributive justice comes in today, which is you only have so much resources, no matter what they're human resources, capital resources to go around. And to me, I think the women of the community are being better served by putting those resources into those other things that women need. 1 out of 4 women have urinary incontinence, as an example. That's 25%. Those women could be served locally now, as opposed to having to be shipped, going to many miles away, actually, to get those services. So again, independently, I just want to, comment on that. I appreciate the comments made. I've taken care of women in this state, and I'm committed to them for 30 some odd years. Women travel far and wide in complicated pregnancies and have done for many, many years with triplets and twins and placenta previas and preterm labor and rupture membranes, all those things we've heard about. And they travel 40, 50, 60 miles to come to Yukon or Hartford or St. Francis and have done so for a long time. But at least from my sense, there's been no abandonment of the women of that community. And indeed, I think a significant commitment.
Okay, thank you. What I'd like to do now is I'd like to take a 5-minute break to meet with my team to see if we have any further questions. So we're going to take a 5-minute break. We'll be back at 5:25. Everyone, please stay muted because everything's being recorded. So it will be recorded if you don't mute yourself. We will be back at 5:25. Attorney Fusco, are you there?
Can you hear us?
I can.
Okay.
Okay, so I want to, is Mr. Pachenko still available?
See if he is.
I'm not sure if he's
I
still
think,
on.
I think he's right.
Yes, I am on.
There you go.
Okay.
Yes, I'm on. Hello.
Hi, so Mr. Pachenko, I'd like to take your oath.
Okay.
Please raise your right hand. Do you solemnly swear that the testimony you're about to give in this hearing is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay, and state and spell your name for the record, please.
Paul Pedchenko, Pedchenko.
Thank you. And Mr. Pachenko, could you tell me what your title is?
I am the EMS program manager for the Windham Hospital Paramedics and the EMS coordinator for the hospital.
Okay, and you testified today in the public comment, is that correct?
I did.
And do you adopt your statement in public comment as, do you adopt that and swear that it's the truth, the whole truth, and nothing but the truth?
I do.
Okay. Just some quick questions, and I don't know if you were listening earlier, but I did ask as part of one of the late files for a sort of more of a some sort of evidence showing the distance and the travel time. And I understand, you know, ambulance time is shorter. I was looking for more, you know, neutral evidence regarding, you know, travel time versus, you know, everyone, oh, it's a 10-minute ride, it's a 20-minute ride. But have you ridden an ambulance from Windham Hospital to Bacchus?
I have.
Okay, and have you driven an ambulance from Windham Hospital to Manchester?
I have, not from the hospital, from the Windham area to Manchester Hospital, yes.
Okay, and have you been in an ambulance from the Windham area or Windham Hospital to Hartford Hospital?
I have.
Okay, so if you were traveling to Bacchus in an ambulance, what routes would you take?
I know I wouldn't be driving the ambulance, but in my history, if I was driving the ambulance, I would drive directly down Route 32 into Norwich to the Route 232 connector, directly into Bacchus, which is right there.
Okay, and is so Route 32, what kind of a road is that?
It's a 2-lane road. It's a state highway.
2-lane road, but meaning?
Yeah, one
Going
one
both
way,
ways?
one the other. Yeah, yep.
Oh,
2 lanes.
there's single lanes both ways.
Single lane both ways, correct, yep.
So it's 32, so you get 32 and 32 takes you right to Bacchus?
Route 32 takes you directly down into Norwich, where you'll encounter the Route 232 connector. And at the end of that connector is Washington Street, where Bacchus Hospital is directly at the end of that road there, when you come off the connector.
All right. And are there many lights on 32?
There are, there's probably 3 or 4, I believe.
And if you are traveling from Windham to Manchester, what's your route? Oh, you're on silent. I think you hit the mute button.
I don't generally drive the ambulance. I'm in the back, but I would assume, depending on where you would be coming from, I believe you would go Route 31 out and possibly to 44 to Manchester.
31 to 44 to Manchester.
Into Manchester, yes.
So is Route 6 part of it?
I believe you could possibly go that way if you were closer to go that way. Like I said, I'm the paramedic who generally is riding in the back. I'm not driving the ambulance.
So you wouldn't know what route you've taken to Manchester?
Well, I've driven to Manchester before, yes.
Okay, but
in my
not
personal vehicle, but maybe not in an ambulance. Yeah.
Okay. And what are the roads like to get to Manchester? On either way, either route?
This is a combination of 2-lane roads.
And when you say 2-lane, you mean single lane each way?
Single lane each direction. I believe there are some parts of 44 that have more lanes, possibly.
Okay. And what would you do to get to Hartford?
Hartford would be Route 6 to 384 to 84 into downtown Hartford.
Okay. You would go on Route 6 on that one.
Correct.
Okay. All right. So I know that's part of the late file. I would like to see a map, and Attorney Fusco, I mean, as another late file, I'd like to see a map that has where all these hospitals are, as far as, so I can see it in one, so I will know the travel time and the mile time and how many miles you're going to provide that. And I'd like to know where on the Connecticut map these hospitals are. I just, in my mind, or just for anyone coming in who's not familiar with Connecticut, to review a file, we need to know the distances we're talking, the travel distances, and how these look on a map.
Okay, and so you would be looking for Windham, Bacchus, Manchester, Hartford. Do you want Day Kimball as well?
Day Kimball, I think, is out in your filing. I mean, these are hospitals that you have referenced in the, in the application.
Okay, yeah, I'll give you the whole central eastern section. That's fine.
Okay, so I know, and maybe I can see the routes, and then you're going to provide me with the time, the travel time and the mileage. Yep. Attorney Fusco, any questions for Mr. Pacheco?
No questions.
Okay, Mr. Wang, Mr. Carney, any questions for Mr. Pacheco?
No, I don't have any.
No questions.
No questions. Mr. Pacheco, thank you.
Thank you.
You're welcome. Mr. Carney, did you have questions?
No, I think I'm all set other than the late file discussion.
Okay, Mr. Wang, I'm sorry.
No problem. I did have some questions regarding financial statements. I was wondering if we can get an updated financial worksheet B for Windham Hospital and Hartford Healthcare for updated fiscal years, given the time that's elapsed since the filing of the CON. So updated financial worksheet B for fiscal years 2020 through 2024.
It's worksheet A. Excuse me, Roy. It's worksheet A, not for profit. Yep.
My apologies. Worksheet A.
That's okay.
Yeah. And then the second one would just be audited statements of operation and balance sheet for 2021 for Windham Hospital and Hartford Healthcare.
Yeah, we would. I mean, are you looking for the audited financial statements for 2021?
Correct.
Okay, so the audited financial statements of the 2021 fiscal year ended
September 30th.
Ended September 30th, and so those audited
until
financial
January.
statements aren't typically ready. We ran into this last year until late January.
Early February.
Early February for this fiscal year.
Would you be able to provide the unaudited?
I don't think we can just, I'm not sure when we would have those, but they typically would not disclose the unaudited, given that they will be audited.
You said the estimated time for audited financial statements is January or February of 2022?
Yes, I mean, we ran into this issue last year with the hearing that was around this time of year where they wanted updated auditeds. And I want to say that they were available for disclosure like the third or fourth week in January. And they can't be disclosed before then. And I can't remember. And I don't know if Cherry Boisvert is still on the call, but there's a reason why they can't be disclosed in advance of that.
I will certainly send
You
you
have to go to the
2020.
the board, to the bond rating agencies before.
That's right. They can't be disclosed
publicly.
before they go, that's right, before they go to the bond rating agencies.
Have the 2020 audited financials submitted already?
Yes. they're on file.
In connection,
2020 is on file with OHS.
but not with
Yes.
this. We filed this in September of 2020.
But we filed already 2020, not with the.
Yeah, so,
CON.
okay, to answer your question, Mr. Carney, they probably haven't been filed in this CON, but they are available. So we could provide 2020 audited. I'm looking to see, did we give you 2019 audited when we submitted this? I think we referenced them. 2020 audited should be on file with OHS.
Yes, they are.
All
right?
right, well,
We can resubmit them, but I believe they are on file with OHS. But when we submitted this application, which was September 3rd of 2020, we wouldn't have had 2020 audited because the fiscal year wasn't over yet. So we would have referenced the 2019s that were on file with OHS at the time. Now, given the passage of time, the 2020s are on file with OHS. We could provide a separate copy, but they are accessible through things I think you took administrative notice of. Attorney Ando.
Yeah, I'm
Think they're in the HRS database, right?
yes, they should be. Maybe you should just submit it to us as part of this, record.
That's fine.
To be safe. So we have it.
Yep.
And Attorney Fusco, you are correct that in the application itself, it only references 2019. So the 2020 would be great.
Yep, we'll give you 2020.
That's all the questions I had, Attorney
Okay.
Ando.
all right. Ms. Reagan, can you go over the late file exhibits?
Sure. So the first one I had is data regarding delivery volume from October 1st to the end of June. I know there was a number stated during the discussion, and there was also a date for the last delivery at Windham Hospital, but just to have that in writing. The second I have is evidence to support the amount of inpatient capacity at Bacchus Hospital.
Is it the capacity for OB at Bacchus Hospital?
Yes.
We're trying to make sure we're taking good notes.
I'm sorry, and I apologize. If we could go back
Oh,
to number
yeah.
one, the doctors were leaving and I had trouble hearing you. So number one,
No,
I
of
have in
course.
my records was the last delivery date at Windham, which we gave verbally, but you want in writing, and then the obstetric volume in writing for that last fiscal year from October 2019 through the end of June.
Correct.
Yeah, and
Okay.
just to follow up, so, I mean, testimony is evidence, but we're going to give more weight to, if you can tell us where this information, where these numbers are coming from. So if your document, you can make reference to where these numbers come from, where you're getting that information. Thanks.
Yes, understood.
Okay, so the second item was the evidence to support the amount of inpatient obstetric capacity at Bacchus Hospital, and also just any documentation to support additional volume and additional patients.
Yeah, so for that one, I think we want to see the most recent completed fiscal year, and then we want some kind of projection going forward. So, where is it now, and will you continue to be able to do that, say, for the next 3 years, support that additional volume?
Okay.
Correct.
Sorry, go ahead.
Oh, no, absolutely. That's important to get the timeline. The third item is birth rates and volumes, both historical and projection, broken down by age and race and ethnicity. So I think we had that discussion with the breakdown of the age, but to add the race and ethnicity as well. The fourth, I have an affidavit of the doctors of Mansfield OB group.
3 years, so we can see a trend.
Sorry,
And
yeah,
it would
3
be
years
for
as well.
each of those hospitals that you provided. This is, there's more than one table. And I'd like to see like the number of patients and the populations and how you arrived at the rates.
These were the, just going back, so I'm losing place of where we are here. So these were the birth rate charts, right?
Yep.
All right. I just want to go back and look at my notes.
Yeah,
the
so it's in the pre-filed testimony.
Yep.
Pages 312, 13, 312, 313, and 314.
Yep. And so you want to see, so what we have in there are simple birth rates for each of the towns within the PSAs of the 3 or 4 hospitals. So you want.
Right, but you just have 1 year. So I'd like to see 3 years to see if we can identify a trend. I know COVID has adjusted that. And then also like, to determine the birth rates, I'd like to see like the patient volume and then the population, just not the rate. And a projection, if you could as well. So those are kind of like the trend of, sort of historical trend, and then what you're projecting going forward.
Okay. For each of those service area towns of each of the hospitals. So we can probably pull the data off of time and then project it out based upon patterns. Okay. Okay, sorry about that.
It's okay.
No, it's good to, thank you, Brian, for the clarification. I just made the notes of the things while we were
Yeah,
having the
It's
discussion,
tricky.
so
It's tricky to do it.
yeah, having the exact detail. And we will, of course, put all this into the order as well. So the fourth item we discussed during the discussion of efforts to recruit and the OB groups from Mansfield specifically. So an affidavit of the doctors of Mansfield OB. We have mentioned Dr. Robert Gildersleeve, who did provide testimony, but also just that they were not willing to come to Windham is what I had in my notes.
Yep.
Number 5 is the documents from the November 29th meeting minutes as part of the operations report. And I reviewed the minutes during break, and there's just the plan that was presented or the presentation to the board, and then the whatever information was shared that led to that vote at the very end of the minutes.
Okay.
Item 6 is the assessment of the 10% of the unknown transportation population and the feedback from the women from the unknown. I believe that was part of Ms. Hanley's discussion when we were talking about the transportation of patients from Bacchus, my apologies, patients from Windham to Bacchus, and there was that percentage of unknown, and that she had mentioned there was feedback and she got information. Yeah, that percent unknown, and just breaking that down, providing more information on that, on whatever information you had collected. Number 7 is evidence to evaluate patient costs for delivery at Bacchus compared to Windham Hospital for commercial and self-pay patients.
Okay.
And let's see. Number 8 is the impact of closure of the obstetrics programs on the financials documented in financial attachment A to include fiscal years 2020 through 2024 and also include all assumptions.
Attorney Ando, I'm looking at my list. I'm not sure if we've asked for this, but you had kind of interjected an additional file based on demographics, race, ethnicity, language preference, age, demographic of women using the obstetric services at Windham. Was that? Oh, you're on mute, Attorney Ando. You're on mute, Attorney Ando.
All right, sorry. Yeah, so I wanted to know not just for, the women in that age group, but also for those using the hospital, the patients that they talked about with the demographics, not that being, age, race, ethnicity.
Language.
Language, yeah, thank you. Yeah, whether English was, a second language, or, whether maybe they don't even speak English. I don't even, whatever information you can give us. I'm just trying to get from the application, I just don't know, I don't have enough evidence to, other than the 82% on Medicaid, what that group is made up of.
Yep.
Women on Medicaid.
Yeah, it's clear. I understand what you're asking for.
Yeah.
So Attorney Fusco, for that particular ask, it may not be best to use the most recent year since there's such a little small volume. Maybe you would use, one that had a more robust volume.
Yep.
Yeah, I mean, if we can go look back a few years, would be helpful. Because I think the demographic chart you have in there goes for a few years, correct?
I believe so, yep.
Mm.
That would be the 9th item.
So historical 3 years, I guess, right? Yeah.
Okay, so the 10th item I have is the strategy and growth plan for Windham Hospital in Eastern Connecticut. just specifically regarding services, termination and stoppage of, and or addition and future changes to services. The 11th one I have is the map that Attorney Ando mentioned and added and discussed at the very most recently. And so that has the travel assessment of all the hospitals, the travel by car and travel by ambulance, and the various hospitals that patients are transferred to. And then the last one I had is the documentation of the Hatch building funds and the those restricted funds for maternity and women's health and rehab services, and just documentation on the application of that to support transportation.
Okay, and you already have the financials on the list?
Yes.
Yes.
Okay. Roy, how many is that?
With the two financials, that
No,
would
how many
be,
on the list? How many items?
12 without the
12,
financials.
okay.
So
All right, Attorney Fesco, how long is it gonna take you to get those documents together?
I think, can we have 2 weeks?
Mhm.
Does
Yeah.
that work for you?
Yeah, let me just look at my calendar. I think 2 weeks is Thanksgiving.
Maybe that.
2 weeks is Thanksgiving. So which side of Thanksgiving do you want?
And do you,
Yeah.
do you want, so that 2 weeks would be,
The day before.
yeah, could we,
24th.
could we get them in that day
Fourth,
before?
it's
That's
just
fine.
the-
What is it, the 24th?
24th.
24th is the day
That
before.
works.
Yeah.
That works, if that works for you guys.
Yeah, okay, so I'm going to issue an order that the 12 items listed by the OHS staff, I'm ordering that those be produced as late files by the applicant and that they be produced by close of business on November 24th. And Mr. Wang, I think you can memorialize that order, can you, in a letter?
I will.
Okay, so I'm issuing the order now, so I don't need to sign it as an order. So I've issued the order on the record. And
Perfect,
if
thank you.
we can just
And I can share that
memorialize
with
it so
you.
we're all on the same page.
I can share that with you, Roy, after we're offline.
Okay. And for clarification, the two financial documents that I asked, should those be included as a individual item on that list? As individual items on that list? If that's the case, then there would be 14 total. I just
Yes,
don't know.
yeah, so the audited financials for 2020, and then, yes, the financial attachment A for Windham Hospital and for Hartford
Correct.
Healthcare.
Yep. So if those two are added, then there is 14 total. Just wanted to get the right number for the record.
Yeah, yeah, well, I just want to make sure, right, so anything that's been listed here is part of that order.
Yep.
Anything else, Brian or Roy?
No, I'm all set, thank you.
All set as well, thank you.
Okay, closing statement, Attorney Fesco?
In the interest of time, I was going to cede my time for closing remarks to the witnesses today, and I appreciate you asking them for follow-up on the public comment, because I think, they said it way better than I could at this point in the day. But, just again, wanted to thank you guys. I know it was a long day and this has been a long process, but we really do appreciate the fact that our voices were heard and that the community's voices were heard. And, I took you through a lot in the opening remarks about CON decision criteria and what's been met. And, I